Шановні колеги, добрий день. Мене звати Вероніка Пацко, я клінічний онколог Національного інституту раку, і ми продовжуємо з нашими лекціями. Сьогодні у нас тема пухлин верхнього відділу шлунково-кишкового тракту, і ми почнемо з презентації професора Лея. Це професор гастроентерології Латиського університету, клініки Латиського університету у Ризі. Він є провідним спеціалістом із скринінгу та попередження пухлин шлунка, раку шлунка. Professor Leja, good afternoon. Glad to see you in here. And so you can start with your presentation. I presented you in Ukrainian, so please go on.
Dear colleagues, dear organizers, thank you indeed for the kind invitation to participate in this important event. And Veronica has already introduced myself, as I have understood. My background is gastroenterology. I'm also a member of the European Helicobacter and Microbiota Study Group. I have been involved for a few years in the Cancer Mission Board of the European Commission. And actually my topics of interest include cancer screening, first of all, digestive cancer screening and prevention. So therefore, it is my great pleasure to be here and to speak today on the topic of gastric cancer screening and prevention. In particular, because specific attention to this topic has been most recently been elucidated by the European Commission, and it's really gaining its importance either in Europe or globally. But first, let's look at the incidence of gastric cancer. And as we all know, it is significantly different in different countries across the globe. And traditionally, East Asia has been known to have the highest incidence of gastric cancer, followed by several countries in Latin America, but also East Europe. And in the case, if we are considering East Europe, definitely Europe is also very variable in the incidence of gastric cancer, but we are speaking more about the central and eastern part of Europe, and countries including the Baltic states, Ukraine, also countries in the Central Asian part of the continent. Those are really the countries with highest incidence of gastric cancer still. And we know very well that if estimated in the age standardized ratio, so meaning standardized data, incidence and also mortality from gastric cancer is declining practically across the globe. But what is important that definitely the starting and the end points of this decline are considerably different between the countries. Yes, it is declining, at least in the standardized ratio data. But if we are considering that global population is either aging or increasing, in this case, we are coming to the figures that the absolute number of new cases is not declining in most of the countries and in most of the areas across the globe, but it's still increasing. And the situation actually is the same also for Europe. If for the current situation, and the current situation is estimated for 2020, gastric cancer has been close to 13% of the new cancer cases across Europe. In the foreseeable future, and here according to GloboCan estimates, the foreseeable future is considered until 2040, the number of new cases is going to increase and the number of deaths from gastric cancer is going to increase substantially in Europe. What we also know, and I will come back to this, that a proportion of deaths could be prevented, and this is estimated at least at 35 to 40%. That means that for Europe, approximately 46,000 of annual cases, mortality cases could be prevented. Of course, that is theoretically in the case if prevention programs are implemented across Europe. If looking at the data for Ukraine, it is also disease, and of course, these estimates have been made before the war in Ukraine started. So definitely we cannot say that exactly the same numbers would be present right now. But in the case, if the very natural cause of the disease in the country, it would be expected that either increase in the new cases or increase in the deaths is going to take place in Ukraine. When looking at the risk factors, and we know that number of risk factors have been related to the changing incidence of gastric cancer, including preservation of the food, when less salty and less pickled food have been used. That has been a very substantial factor to decrease the incidence from gastric cancer. Also antibiotics, also smoking. But currently the predominant and absolutely the key risk factor is the presence of Helicobacter infection. So that is the important factor, but also the prevalence of Helicobacter is declining. I will speak on this a bit later. But now, in respect to the prevention strategies, and we could split between the primary and secondary prevention strategies of gastric cancer. And the secondary prevention strategies would include search for early gastric cancer when it could be cured even with endoscopy, or search for precancerous lesions, atrophy, intestinal metaplasia, and dysplasia. And if we do know those individuals with high-risk lesions, we can apply surveillance strategies to them. While the primary prevention strategies seem to be more effective in gastric cancer mortality prevention, and first of all, it would include the reduction of the transmission of Helicobacter in the family, first of all, but also the diet and lifestyle factors. But also Helicobacter eradication, meaning giving the treatment to get rid of Helicobacter, is considered as primary prevention strategy. And this could be applied either whether in high-risk groups or in the general population. So when speaking on screening, in Europe, it is considered that screening always is effective in the case if it is organized, if it is systemic, population-based, involving all the eligible population. At the same time, risk stratified screening also could be included to the program. Definitely, it should be evidence-based, and the risks have to be balanced according to the benefits. So the safety, ethical aspects should be considered as well. And equity aspects are given a particular attention currently in the European guidelines. So coming to how we can screen for gastric cancer. It is not really so straight ahead, only one single way of cancer screening in the case of gastric cancer. There could be few different approaches. First of all, it could be screening for cancer itself. And this is this is an approach that is being used in East Asia, in Korea, in Japan. It could be done by endoscopy. Previously, it was done solely by X-ray screening. But once more, those programs are effective, and this has been documented only in East Asia, and the effectiveness outside this area has never been proven. Then we could screen for precancerous lesions, and this could be done whether by endoscopic screening or with serological approach, and pepsinogens are the best defined markers as for today. And finally, it could be screening and treating for Helicobacter, so-called screen and treat strategy, meaning screening for Helicobacter in asymptomatic individuals in general population and offering eradication treatment in the case if it is possible. Let me stop a while on the two last aspects. So first of all, screening for precancerous lesions. And as mentioned, those could be two different approaches. I was mentioning pepsinogens, and I assume that in Ukraine also the test panel, usually with the commercial name Gastro panel, has been including also Gastrin 17. The idea would be to, since this parameter would be more indicative for antral atrophy, but unfortunately the accuracy for the tests is not so good as one would expect. And I would just quote our own study, what has been done in gastric cancer patients. We have been measuring pepsinogens and gastrin 17 in patients already with established gastric cancer. Decreased pepsinogen levels were found only in 1/3 of the cases, but decreased gastrin 17 levels were just present in a bit more than 10%. How we can interpret this? In the case, if we apply this approach to general population, although I really have been strong supporter of this approach, but we have to acknowledge that 2/3 of patients with already gastric cancer would be missed with them if screening with the pepsinogens, and actually gastrin 17 does not add too much to this accuracy. This has been actually shown, but Asian data are a bit better than our European and also Latin American data. There are several meta-analyses. In general, being an agreement that specificity of pepsinogen testing is quite acceptable, but the sensitivity is rather low. Here in this meta-analysis for gastric cancer, 59% sensitivity and 73% specificity. So guidelines on gastric precancerous lesions, and I assume that some of you might know this. Those guidelines, they are called MAPS guidelines, Management of Epithelial Precancerous Conditions and Lesions in the Stomach. This is already the second edition of MAPS guidelines, and currently the third edition is under preparation. So I assume that during the next year, we are going already to discuss the third version of MAPS guidelines. Those guidelines are defining the control intervals of patients with precancerous lesions. But what is really important, you need to have a very qualitative endoscopy and very qualitative pathology to assess the precancerous lesions. It's a very old Sydney protocol recommending that 5 biopsies from different departments from stomach have to be taken to evaluate the mucosal status of the stomach mucosa. And this is in the case if no visual lesions are being seen. We can debate on the role of incisura biopsies, but 2 biopsies from the antral part and 2 biopsies from the corpus part are essential. This will be once more elucidated in the new guidelines on gastritis that we are expecting to be published quite soon. Then, and I'm not going to go deeper into pathology since very well-known pathologist Maria Blanca is going to address those aspects in the next speech. But nevertheless, the Olga and ogive staging systems are gaining really the acknowledgement. But what I would like to emphasize from my point, and I hope that Maria Blanca will support me on this with her data that are very important, that really stage 3 and 4 are very high-risk stages. Stage 0 and 1 are low-risk stages, but actually I cannot agree with the author of this classification that stage 2 is always a low-risk stage, because actually this stage could include also patients with high risk. And I'm just referring to our recent publication where we were giving back to the individuals having developed gastric cancer and having undergone qualitative endoscopy few years before the cancer development. This was out of 1,500 individuals, more than that have been endoscoped. We got 5 such cases where we could look back. And what is important here, that few of them had low Olga and ogive stages, but all of them had incomplete intestinal metaplasia at the enrollment. And all of the 3 patients in whom we could do the subtyping of intestinal metaplasia in more detail, it was type 3 metaplasia. Recall this just when listening to the next speech. So finally, coming back to screening for Helicobacter. And this is a map of the Helicobacter prevalence. Also, the prevalence of Helicobacter is declining. Older years on the top, younger years on the bottom. So that is definitely the true, but Helicobacter is not going to be disappearing problem by itself. It might be, but it will take centuries, so probably we cannot wait this. The initiatives globally have been coming from Taiwan, in particular from Matsu Island, that is an island next to the Chinese border and belonging to Taiwan, where mass eradication strategies have been carried out, demonstrating more than half of the reduction in gastric cancer incidence and 25% reduction in gastric cancer mortality. Currently, is ongoing in China. Actually, the study has been already completed, at least the data are being analyzed, and hopefully we are going to see the results of the study already this year, because 1,800 individuals have been randomized for 2 treatment arms in this study. So large number of gastric cancers have occurred meanwhile. So the final results are not available. And as mentioned, we would expect to have them even during this year. So meta-analysis conducted by Paul Moyedi's group has estimated that we need to treat 72 healthy individuals to prevent one gastric cancer case. And we need to eradicate 135 individuals to prevent one death case from gastric cancer. And somebody might consider that those are large numbers, but I would like to try convincing you that it is not. It is very, very small numbers of patients to be treated for cancer prevention. And this is the case if you compare this according to the screening. So a couple of documents that we do have and recommendations right now. First of all, Kyoto Global Consensus, already close to 10 years ago, first time named Helicobacter gastritis as an infectious disease that has to be treated whenever identified. And Type A Global Consensus has called for population-wide screening and eradication of Helicobacter, that this has to be integrated to the national healthcare priorities for better management. However, we are also aware that increased antibiotic use might result in antibiotic resistance, and those are the data from WHO, having estimated that by 2050, more patients would be dying from antimicrobial resistance-related issues than from cancer in total. So how to balance this? And indeed, we need to acknowledge that antibiotic treatment for eradication is causing gut microbiota perturbation. And those are the data from our recent study that has been accepted for gut, that even 6 months following the clarithromycin-based triple therapy, resistant genes were found in gut microbiota, although this was not seen in the other therapies without clarithromycin content. So now I'm coming to the recent European Council recommendations on cancer screening, and those recommendations have been updating the previous ones dating back on 2030. And for the first time, 3 new cancer types have been included to those guidelines. It is lung cancer, it is prostate cancer, and it is gastric cancer. And here is what we do have on gastric cancer in those guidelines. First of all, the approach that should be targeted is screen and treat for Helicobacter, but second, also addressing the precancerous stomach lesions to prevent gastric cancer. And number of activities have been initiated thereafter to design the best recommendations for Europe. This is a project I'm the honor to lead, TOGA's project on gastric cancer screening implementation for EU. And we expect, or the European Commission expects, that guidelines would be developed on how really this should be dealt. 3 different pilots being run. Pilot 1 is addressing Helicobacter in young age individuals, 30 to 35 years old. Pilot 2 is addressing already eradication in middle age individuals, in subjects undergoing colorectal cancer prevention. And pilot number 3 is our G-STAR study we are running in Latvia. That is going to address the long-lasting potential adverse events. And we are going to broadly disseminate the results of this broad working group And 3 years in a line, we are going to run special outreach meetings that will be held on the previous day before the European Helicobacter and Microbiota study group meeting, and the first of the meetings will be held this year, September 7th in Antwerp. The registration of the event is open, and even in the case if the colleagues that are interested in this cannot make it this year, I hope that for the upcoming years it will be much more easier for you to travel and to participate in person, but also online participation will be possible. So what should be ideal scenarios for gastric cancer prevention? First of all, to decrease Helicobacter transmission. Second, invasive identification of Helicobacter and identification of the individuals that have higher likelihood in progressing to gastric cancer. Ideally, in the case if we could have a simple and easy to use low-cost device for early gastric cancer detection, or perfectly in the case if in this way we could detect precancerous lesions. And finally, and that we already do have now, eradication therapies, but with the medication that are not expected to induce significant resistance. So just to illustrate the third point of this, and we had the pleasure of working with the National Cancer Institute in Ukraine on such project. A breath test analyzer that was developed, and the testing has been started with this project to identify the likelihood of increased gastric cancer likelihood from the exhaled breath. Furthermore, what would be very much important is to gather as much as data from different data sources, from different studies. And we do have a project with the acronym CARACOL approved in the European GAIX database. And the idea is to have data from different projects put together in one unique database. And we very much plan to really develop this further during the upcoming screening projects in Europe, also actually where Ukraine is going to participate. And last but not least, we are going to launch a survey to medical professionals. Mainly it will be addressed to general practitioners and community gastroenterologists. We are going to, and the aim is to collect the feedback and to opinion from practicing physicians on gastric cancer prevention. We expect this to be translated to many EU languages, and I would encourage also to have it to get it translated to Ukrainian language and to gather the data on the specialist opinion in this respect. And with this, I want to thank you for the attention. I would be happy to take questions. And I would like to finish with this photo that was taken just last Sunday of the unique event that is occurring in Latvia every 5 years. It is called Song Festivals. And there are more than 17,000 singers, choir singers on the stage. And I have to say that one of the songs in their very official program was developed to Ukraine, and there was a Ukrainian voice choir participating in this event as well. Thank you.
Professor Leja, thank you very much for your great talk, and we also appreciate the help and support of Latvia to Ukraine because you are doing really a lot. So we really could feel it, and we thank you all for that. While you were talking, I had a few questions in my head, and even wrote it down, but step by step you answered some of them. So one of them was like, what is the optimal age for H. pylori screening? But you said that it's like 30, 35 years in countries with high risk of gastric cancer, with high incidence of gastric cancer. Am I right?
Actually, we do not have the exact answer for this. And that is a reason. That is what we are planning to address in the studies. Theoretically, yes, because in this case, we could try avoiding also the transmission of Helicobacter in the families. But also screening, the compliance might be lower in this age group. So alternative could be at the age of 50 or around this, but then we need to understand whether a considerable proportion of individuals at this age might have passed already the so-called point of no return, when gastric cancer might be developing irrespective to the eradication.
Thank you. And also the other question, but you dedicated 2 slides to this, is whether there is any influence of this antibiotic therapy of Helicobacter. So we can't just treat everyone and give everyone the treatment. It's better to select this patient. And are there any criteria of selection for patients like this?
Unfortunately, we cannot really define concrete criteria at the moment, although we would like really to have it. Currently, the recommendation is to treat everybody, but to choose the treatment that is really less causing or potentially causing resistance. Avoid clarithromycin, avoid levofloxacin in those treatments, use other medications like quadruple therapy. The problem is that those medications might not be available in all the countries. We are going to have new generation of acid suppressive agents that currently already one of such projects is vonoprazan is on the market in Asia, not in Europe. And at least data from Asia are suggesting that maybe one antibiotic combined to this might be sufficient to eradicate, but the European data so far have not supported this.
Okay, and last from my side, do you know any examples of countries in Europe to be as successful as Japan and South Korea for gastric cancer screening?
I don't think there are neither countries in Europe nor elsewhere that are so effective. And currently, the first country that is very close to implementation of nationwide program, and actually they are starting this within 2 of the currently running projects, that is Slovenia. But because we need also to select the appropriate countries, because such approach might not be effective in countries with low incidence of gastric cancer. But I assume that either in Ukraine or in the Baltic states, that could be a beneficial approach.
Thank you very much. Чи є питання ще у когось до професора Leja? Professor Leja, thank you very much for your great talk and for your time. Thank you for joining us. Still, we have no additional questions, and so we can go on. If you would like, you can stay. Your really good friend of yours will continue our conference. So, do we have a next speaker? Yeah. So, I would like to continue with upper GI tumors, and we will go on for pathology. And I would like to introduce to you Dr. Blanca Piazuelo. I'm afraid to mispronounce it, and so she will give a talk about histopathology of gastric and precancerous lesions. Зараз хочу представити вашій увазі лікаря Марія Бланка Piazuelo, яка буде доповідати на тему патогістологічні особливості передракової слизової передракових утворень шлунка. Maria Blanca, good morning, I guess. Can you hear us? You're muted. Maria, you're muted. Hello? Maria Blanca, good morning for you. You can start. Now we can hear you. No, we can't hear you.
Okay, good morning.
Oh,
I'm sorry,
great.
I'm sorry.
Yeah.
Good morning, everyone. I'm sorry, I'm a little messed up with this thing. Now that Mārcis was talking about what I should be talking, I wasn't prepared, so I was trying to add a few slides more to talk about what he wanted me to say. So I apologize for the delay, the small delay, but I'll be ready right now. Let me open my talk and share my screen now.
Meanwhile, I would say that Maria Blanca is quite famous pathologist in North America, and she's working in a city that's called Nashville, in the Vanderbilt University, and she is working as a pathologist together with as a researcher in a lot of international projects that are dedicated to precancerous lesions in gastric cancer and also in screening of gastric cancer. So, are you ready with your presentation?
Thank you so much for the kind introduction. Can you see my screen now?
No, not yet.
No? Oh my God, I'm so sorry. Thank you. Okay, good morning, everyone. Sorry for the technical glitch. It is truly an honor to participate in this important conference, and I appreciate the kind invitation. I'm going to talk about the precancerous process of the stomach from the histopathological point of view. First, this is my outline. First, I will go through the Correa cascade, making emphasis on the definition of gastric atrophy. Then I will quickly mention about the Olga and Olgin system for the identification of patients at increased risk of gastric cancer. Third, I will emphasize about the importance of subtyping intestinal metaplasia. And finally, some considerations in gastric cancer of the intestinal type versus diffuse type. I may be packing too much in this talk now, but I'm trying to go quick. In the Correa cascade, I wanted to bring attention to these two stages of that represent gastric atrophy. In the stomach, atrophy is defined as the loss of native functional glands, whether replaced or not by other type of mature epithelium. Therefore, intestinal metaplasia is part of the atrophic process of the stomach. All of these terms are used sometimes interchangeably for gastric atrophy. The first one makes reference only to the plain loss of glands. The second one, the gastritis term, makes reference to the inflammation in the stomach. And I like the third one because it emphasizes the multifocal nature of the process. So multifocal atrophic gastritis is a broad term that includes atrophy without metaplasia, with intestinal metaplasia, or with pseudopyloric metaplasia. And I'm going to go quickly through those. I am sorry to bring pathology 101 quickly review of the histology because this is important to understand for the Olga and Olgin classifications. So this is normal antral mucosa, and when these glands are lost is what we call atrophy. Usually after years and decades of inflammation in the stomach, this is what may happen. This is a case of atrophic gastritis without metaplasia, and you can appreciate that there is severe loss of glands, only a few are remaining. Also, the stroma shows fibrosis, which is stained pink in these bands, and there is also a ground of inflammatory cells that you can see all around. And here is intestinal metaplasia, where the gastric glands have been replaced by intestinal epithelium, which is recognized mainly by the goblet cells. In the corpus, the oxyntic mucosa is composed by glands that are mainly straight and mainly composed of these parietal cells, which look pink here. And at the bottom, there is chief cells at the bottom of the glands. This is a case of atrophic gastritis without intestinal metaplasia. So in this case, you can appreciate it with the same magnification. So the mucosa is thinner, and there's a marked loss of parietal and chief cells. The glands are kind of disorganized, and there is also, in this case, a background of inflammatory infiltrate. And this is a case of intestinal metaplasia, which can be appreciated on this side. And on the left corner, lower corner, there is still a remaining a small group of oxyntic glands, which are atrophic. But in some cases, even the corpus mucosa or the entire biopsy can be replaced by metaplasia. And you cannot, as a pathologist, you cannot know that that was at some point oxyntic atrophy. So this is why it's important to separate biopsies from antrum and corpus before processing. In the corpus, there is another type of metaplasia, which is pseudopyloric metaplasia. And I was going to show you this case on the left side. You can appreciate that these are normal, more or less normal oxyntic glands. In the center, you can see that these glands are smaller. There is a marked loss of parietal and chief cells. And here on the right area, with higher magnification, you can observe that this gland has lost completely the oxyntic phenotype. So they look like antral glands, and here is another gland that is going through the same process. So when this happens extensively, it is difficult from the biopsy to know if this was corpus or antrum. You may be familiar with the term SPEM in the literature, which refers to pseudopyloric metaplasia in animal models of gastric injury. This image is corpus mucosa of a gerbil, which has been infected with Helicobacter pylori. So you can appreciate here, these big pink cells are parietal cells that are remaining. At the base of the glands, the chief cells are completely lost, so you don't see any. And these glands have been replaced completely by epithelium that shows mucose phenotype. So this is what we call pseudopyloric metaplasia. And in animal models, Golden Ring actually coined the term at Vanderbilt as SPEM. So the thing is that when you see the term metaplasia in animal models, you have to be aware that most of the metaplasia in animal models is just this type of metaplasia. It's not intestinal metaplasia as we see it in humans, because the animal models do not quite reproduce the intestinal metaplasia that we see in the human stomach. So I reminded you about the atrophic changes in the stomach because they are the basis of the Olga and Olgin systems. So I'm going to quickly go through some of the issues. So these are there's plenty of evidence that shows that the histological extent of atrophy, all the atrophic changes in the stomach, correlate with the risk of gastric cancer. And these two systems are supported by international guidelines to identify individuals that could benefit from endoscopic surveillance. So I'm not going through this because you already know 5 biopsies, separately in antrum and corpus. And what I wanted to mention, the main message that I wanted to bring here is that the Olga system evaluates the extension of all histological variants of atrophy. I am sorry, I went back. All histological variants of atrophy combined. So it includes non-metaplastic atrophy, intestinal metaplasia, and pseudopyloric metaplasia. And all the 5 biopsies are assessed by the extent of these lesions, and then the corpus and antrum are combined, and this gives yield to the stage. So when you see the word atrophy here, atrophy means everything, all variants, because this has been misinterpreted, and you can see that even in the literature, there is confusion when they classify a patient with Olgin-1 with intestinal metaplasia, and then they say that it's Olga 0. You cannot have a patient Olga 0 if you have intestinal metaplasia. The organ system, in contrast, only assesses the extent of intestinal metaplasia, as we saw. So I'm going to show you, this is one biopsy, so the pathology should go through 5 biopsies per case, but I'm going to show you in one single biopsy the difference between these 2 systems. This is a biopsy with severe loss of glands. You can appreciate here that there's no glands here. And there is some areas that we can show you. I can show you here is intestinal metaplasia, and there is intestinal metaplasia here. With the Olgin system, if you only score intestinal metaplasia, this is what you see. You can estimate that about 30% of this biopsy, the stomach has been, the gastric mucosa has been replaced by intestinal mucosa. But if you apply the Olga system, you can see that probably just 10% of the glands that were originally gastric glands are remaining. So an Olga for this biopsy would be about 90%. So this is why the Olga stage cannot be lower, never can be lower than the Olgin. It could be equal or more advanced, but never less advanced. And both systems have been extensively shown to be useful. This part is of the 20-year follow-up of the Colombian cohort of precancerous lesions that Dr. Correa started in the 1990s. And this table has too many numbers here because this is Olga stage at baseline and patients that a 20-year follow-up. The patient. But what I wanted to show you mainly in this figure is that most of the patients that developed cancer were stages 3 and 4 at baseline. So for this, there was only one patient that was stage 2. When we applied Olgin, and these are stages at baseline, we found the same trend. More or less the same. Most of the patients that progressed to cancer were Olga stages 3 and 4, Olgin stages 3 and 4, but we see more cases that had lower Olgin stages that progressed to cancer. One issue besides the Olga and Olgin, another issue that has been considered in the guidelines is that some of the guidelines say that intestinal metaplasia limited to the antrum is considered low risk, and it shouldn't be followed. So I have an issue with that because I think you can have a very extensive intestinal metaplasia in the antrum and the corpus be spared, and still you're at stage 3. So this is an example, it's an extreme example, but it's not rare that can happen. That you can have 3 antral biopsies with intestinal metaplasia, more than 60% of the biopsy, and probably you don't see the intestinal metaplasia in the corpus, and that patient is at stage 3. So I think when you have only antral metaplasia, you cannot automatically say that it's a low-risk patient. Every patient should be individualized. And this is just to compare 2 extreme cases in which, according to the guidelines that says only antrum, if you have only antrum, don't follow. And if you have corpus, you should follow. Not always, because I'm comparing 2 extreme cases in which this case will be considered, this patient will be considered just limited with a very extensive antral metaplasia, and even without considering the subtyping. So this patient should be considered extensive when you have a small foci. So I think this should be, every patient should be individualized. And this is our thing that even extensive metaplasia with the Olgin system, even the extensive metaplasia can be considered as low risk, because this is a patient that may have intestinal metaplasia in all biopsies, but here you will have an stage 2 because it's only up to 60%, and you make an average. So anyway, you will have a stage 2, and this will be stage 1 because it's 30% only in the corpus. So this patient could be classified as stage 2, even having intestinal metaplasia in all biopsies. So again, this is why the pathology shouldn't be just be focused on the stage, but every patient should be individualized. Now, intestinal metaplasia is recognized as a risk factor for gastric cancer, but it's a very heterogeneous lesion. And the most important thing is most patients with intestinal metaplasia will never get cancer. So there are several classifications, but the most commonly used is the one that recognizes complete and incomplete. You may have seen this a lot of times, but anyway, the complete type is characterized by well-developed goblet cells, brush border, and panet cells. And the incomplete type, which is the one that is most associated with progression to cancer, is characterized by smaller goblet cells, which are not so well-developed and so noticeable. There is absence of brush border, or maybe very faint. And the intermediate cells are columnar cells that have mucin droplets of variable sizes. So I want to emphasize that these are two very characterized examples, but the task for the pathology is not always this easy. There is a lot of mixture and a lot of, it's not as black or white always. And I brought these other two cases of complete and incomplete to point out to architecture of the glands. Because in the complete type, usually, not always, but usually, the glands, the crypts are straight or slightly curved. But in the incomplete, sometimes you can see these irregular glands that are more complex, even with branched glands. So this is one characteristic of the incomplete. Our classification is by Filippi and Jas, which recognizes three types. The type 1 is the complete type that we just looked at. And the incomplete type includes type 2 and type 3. This classification requires special stains, which are not performed everywhere. But again, the incomplete type is the one that has more risk of progression to cancer. And what I wanted to emphasize is that the type 3 that Mārcis mentioned in his study, the type 3 among these two is the one that is associated with a higher progression to cancer, and is characterized by the presence of sulfomucin, which are stained brown with the HID Alcian blue stain. Fortunately, there is an increased interest in subtyping for clinical practice, at least into complete and incomplete. In 2020, the AGA technical review of 7 studies found a relative risk of 3.3 for the incidence of gastric cancer in individuals with incomplete metaplasia versus complete. So the evidence keeps accumulating. That was 2020. Several papers are after that. This is our follow-up of the Colombian cohort, 20-year follow-up. And what we found is that in a multivariable analysis, we showed that individuals with incomplete metaplasia were 13 times more likely to progress to cancer than those with the complete type. And here are the risk of progression to cancer, the rates of progression to cancer by 100 person years for those who started with complete or with incomplete metaplasia. Mārcis already talked about his paper. I knew he was going to mention, so I didn't. I'm not going to go into detail, but this is a nice study. And basically, what they found is that all individuals who developed cancer had incomplete metaplasia in a previous endoscopy. In the Colombian cohort, we also found that the proportion of individuals with incomplete metaplasia increased significantly with the Olga or Olgin stages. So these are individuals who, percentage of individuals, for example, in stage 4 that have incomplete metaplasia. And this finding is not new, but it supports other studies about the association of incomplete metaplasia with the extensive metaplasia. So in clinical practice, this could be important because the number of biopsies collected may be insufficient or inadequate for Olga or Olgin staging. But if there is presence of incomplete metaplasia, that could be considered a surrogate marker for extensive metaplasia. And I wanted to clarify that when we talk about the incomplete type, we may be referring to either pure incomplete metaplasia or more frequently mixed metaplasia, which has characteristics of both. Here is an example of a gastric biopsy where you can appreciate the goblet cells. So I marked the areas where here you can see gastric normal mucosa and this little area. And the rest is all a mixture of intestinal metaplasia, complete and incomplete. Here you can see the goblet cells, and here you see very well, the Paneth cells. These pink are Paneth cells at the bottom of the glands, but in these other crypts, you don't see them. And you see very well developed goblet cells here, but you don't see them here. So in a high magnification, you can have a mixture like this. One gland is incomplete, the other is complete, and the next one is incomplete. So this is just an example of how mixed it can be. So this shows also that all you can need as a pathologist is a good, well-oriented biopsy, a good-oriented tissue, and a good H&E to classify between complete and incomplete. Usually, special stains are not needed. In case you need it, you can do the Alcian blue. That is one of the stainings for the Philippe classification. And what this stain shows is that the blue, all stained in blue, is intestinal mucins. So in case of doubt or very small foci, you can recognize them easily with this staining. The pink staining is stomach, normal gastric mucosa. And here you can appreciate the multifocal nature of the process that we talked about. So this is complete metaplasia. And here is an example of incomplete metaplasia with Alcian blue pass. Here is normal epithelium, and all this area is incomplete, which shows a mixture of the intestinal mucins and the gastric mucins. And one final word that I wanted one final thing that I wanted to bring about intestinal metaplasia is that according to Lauren, carcinomas are classified in intestinal or diffuse. And when Dr. Correa described the precancerous cascade, he found the precancerous process to be mainly relevant for the intestinal type cancer, which were the most frequent. So the idea that intestinal metaplasia is only associated with the intestinal type tumors has remained. However, intestinal metaplasia can be observed in a large percentage of diffuse tumors. This is an example of signet ring carcinoma, which is, as you know, a type of diffuse tumor. And here you can appreciate the tumor cells, which are these round, clear cells, and are surrounding islands of intestinal metaplasia. So going back to the original paper by Lauren, he described in 1965 that 91% of the cases of intestinal type gastric cancer had surrounding intestinal metaplasia, but also this metaplasia around the tumor was found in 55% of diffuse tumors. So it is not rare to find intestinal metaplasia around diffuse tumors. And there is a recent meta-analysis that reported that intestinal metaplasia was associated with diffuse type cancer. So this paper analyzed the data available assessing the association between these two entities, and they found a significant association with a pool ratio of 2.3 for the presence of intestinal metaplasia in diffuse cancers. So both intestinal and diffuse are associated with metaplasia. The same study analyzed Olga and Olgin stages in diffuse tumors and found that compared to low-risk stages, high-risk Olga and Olgin stages were also associated with increased risk of diffuse type cancer, with pooled ratios. This is Olga, this is Olgim, with pooled ratios of 1.7 and 1.9, significant. So all these findings together suggest that a considerable portion of diffuse tumors develop through the atrophic precursor lesions. And this is finally my take-home messages. Atrophic gastritis includes metaplastic and non-metaplastic variants. Olga staging includes all variants of atrophy, including intestinal metaplasia. Olga stage can be equal or higher, but never lower than the Olgin. The surveillance in individuals with intestinal metaplasia limited to the antrum or with low-risk Olgin stages should be individualized. The subtyping of intestinal metaplasia is useful in the classification of gastric cancer risk and should be adopted in clinical practice. And a considerable proportion of diffuse type tumors may develop through the Correa cascade. And here are the people that contributed most to the data that I presented from the Colombian cohort and the founding sources. And finally, thank you again for the invitation. I wanted to say that under the current situation of Ukraine, we are aware that the medical and scientific community has been severely affected. But also we have seen the strength and the resilience of Ukrainians. So this is temporary and the community will come back stronger. Thanks for your attention, and I'll be happy to take any questions.
Maria Blanca, thank you very much. It was really interesting talk, and we appreciate your support and that you came for our conference. Unfortunately, we don't have pathologists. Right now we have a lot of surgeons, but mostly so we're just now trying to go through all the information that was received, and we can ask anything qualified. So we really appreciate for the information that was given. It is very important for both and clinical oncologists and for surgeons. And thank you very much for your time. And you're welcome to be present for the other lections. And thank you very much. І я б хотіла зараз продовжити і запросити до слова президента Української спілки хірургів-онкологів із доповіді щодо лікування раку підшлункової залози. Будь ласка, Андрій Володимирович, вам слово.
Дякую, Вероніка Володимирівна. Перш за все, хочу всіх привітати з участю, з ті присутні, хто у нас дивиться нас онлайн. Ми відновлюємо роботу нашої асоціації після певної перерви із-за того, що, всі ми розуміємо, були важкі часи і для компаній, які нас підтримують. І спікери українські не всі мали можливість до нас приєднатися як раніше, але ми, я сподіваюся, продовжимо працювати в інтенсивному режимі, як це було до війни, десь в середньому раз на 2 місяці будемо проводити тематичні, як мінімум, онлайн наші заходи. А також я хочу також ще раз повторити, що наша основна організація, Європейська асоціація онкохірургів, в рамках нашої асоціації дозволяє безкоштовну реєстрацію всім, хто з України, а також безкоштовну реєстрацію на заходи, які проводить Європейська асоціація онкохірургів. І тому рекомендую особливо молодим онкохірургам звертати на це увагу, бо є більш упрощена система стажування і також можливість отримувати гранти на відвідування в рамках нашої асоціації, Асоціації Європейської, всіх заходів, які є в анонсі на їх сайтах. Отже, сьогодні моя презентація про лікування рака підшлункової залози. Це лекція, вона при підтримці одного з наших провідних спонсорів компанії Servier, яка також підтримує, що дуже важливо, не тільки освітні конгреси для лікарів, а також освітні програми для пацієнтів. І ми вже зробили з ними, ви можете на сайті нашого інституту подивитись програму по підтримці пацієнтів з колоректальним раком. Зараз починаємо програму по підтримці пацієнтів освітню по раку підшлункової залози. Сподіваюся, вона також буде цікавою як для пацієнтів, так і їх сімей, а також для лікарів різних направленостей. Отже, у нас була можливість відвідати АСКО в цьому році. І я хочу трошки зробити рев'ю, які основні напрямки проговорювались по які актуальні напрямки вважаються тими, що потребують подальшого вивчення в рамках провідних спеціалістів Сполучених Штатів. Отже, які основні питання проговорювались по хірургічному лікуванню рака підшлункової залози? Це результати досліджень, які можуть відповісти на питання, наскільки ми можемо і треба робити передопераційну лапароскопію про раку підшлункової залози, наскільки треба робити великі резекції при артеріальній інвазії рака підшлункової залози, і чи є різниця по результатам лікування між відкритим та лапароскопічним ПДРом. Я коротенько пройдусь по цим питанням. Отже, ви бачите місцево розповсюджений рак підшлункової залози. Перший слайд – це потенційно резектабельна, другий – гранично резектабельна пухлина, і третій – це нерезектабельна пухлина. І, відповідно, які методи можуть нам давати ступінь розповсюдження пухлини, з якою точністю до операції. Бачите, ендоскопічне УЗД 85% точність, КТ 88%, МРТ 83%. Відповідно, питання, чи можемо ми це покращити шляхом лапароскопічного стадіювання. Основна проблема, що при місцево розповсюдженому раку буквально третина пацієнтів вже має віддалені метастази, які ми можемо візуалізувати шляхом лапароскопії, але обмеження КТ-МРТ десь пів сантиметра. На це при такому розмірі ні КТ, ні МРТ, ні ПЕТ-КТ не дають нам диференціальної діагностики. Це потребує, на думку авторів, які презентували результати досліджень, проведення стадіювання перед плануванням неадювантної хіміотерапії і перед початком хірургічного втручання. Основні цілі ви бачите виявлення мікрометастазів, які ми не бачимо на КТ-МРТ, зниженням смертності відповідно від непотрібних методик лікування, тому що ви знаєте, протокол неадювантний він один, протокол лікування метастатичного раку він інший. І відповідно це також вирішує питання пояснення пацієнтам і родичам, чого в них погані результати, якщо б ми проводили неадювантну хіміотерапію пацієнтів з метастазами без попереднього стадіювання. Ми, скажу заздалегідь, достатньо давно використовуємо дану практику при лікуванні рака шлунка, і відповідно це знімає дуже багато питань в плані подальших прогнозів і подальшого лікування пацієнтів, коли ми розуміємо чітко стадію до початку лікування. Відповідно, результати досліджень введені на сьогоднішній день в протоколи NCCN. Це дослідження, яке показувало вивчення, в тому числі лапароскопічного стадіювання. Я не буду зупинятись на дизайні. Ви бачите, що лапароскопія дуже в суттєвому відсотку, майже в 30% змінює стадію пацієнтів. Відповідно, на сьогоднішній день це є рекомендацією до виконання при плануванні особливо неадювантної хіміотерапії при місцево розповсюджених нерезектабельних формах рака підшлункової залози. Друге питання – периневральна інвазія рака підшлункової залози, або це майже можна ставити рівно до артеріальної інвазії, тому що особливості анатомії підшлункової залози пов'язані з тим, що розповсюдження раку аденокарцинома відбувається інфільтративно вздовж нервових стовбурів, які дуже інтенсивно представлені в зоні черевного стовбуру або в зоні устя верхньої брюшової артерії. Відповідно, рак підшлункової залози, як правило, розповсюджується в напрямках нервових стовбурів, далі на сегментарні гілки артеріальні. Відповідно, патологоанатомічні дані, опубліковані в канцері 2009 рік, показали, що є при такій інвазії мікрометастази, які розповсюджуються далі кров'ю. Відповідно, є питання, наскільки це пацієнти з місцевим раком все ж таки розповсюдженим, чи це вже пацієнти з розповсюдженою хворобою. Проведено декілька рандомізованих досліджень, які вивчали в тому числі безпечність виконання даних операцій, віддалені результати і біологію пухлин, яка може нам сказати, чи треба таких пацієнтів взагалі планувати на радикальні операції або ні. Ви знаєте, що це дуже така хірургія, яка повинна виконуватись лише в високоспеціалізованих центрах, які можуть забезпечити весь комплекс як передопераційний, післяопераційний супровід. Це пацієнти, які йдуть спочатку на неадювантне лікування, і в подальшому, чи можливо їх буде прооперувати взагалі. І мені сподобалось тут, відповідно, ви бачите, що неадювантна хіміотерапія значно може покращити лікування таких пацієнтів, але по ітогу, який же відсоток пацієнтів проходить хірургічне лікування? Я зразу перейду до статистики автора. Основна, щось в мене збой по презентації. Дисконект. Чи я цю просто можу, так? Основні зони повернення – це, як ви бачите, не місцевий рецидив, це в основному віддалені метастази. Відповідно, автори роблять таку загальний аналіз із 100 пацієнтів з місцево розповсюдженим раком підшлункової залози, скільки пацієнтів виживе і які в них будуть питання. Із 100% ви бачите, що буде 30 пацієнтів, в яких дійсно немає віддалених метастазів, і на індукційній терапії, на неадювантній терапії 70% пацієнтів відпадуть, тому що ми в них будемо діагностувати віддалені метастази протягом цієї неадювантної хіміотерапії. І з тих 30 пацієнтів, яких ми по ітогу візьмемо на радикальну хірургію з артеріальною реконструкцією, 5%, на жаль, загине із-за високої смертності навіть в найкращих умовах, в найкращих клініках, де виконуються такі операції. 28 пацієнтів виживуть, із них тільки 8 пацієнтів по ітогу будуть мати 70 пацієнтів знову будуть мати віддалені метастази, і 8 пацієнтів будуть мати локальну прогресію. І, на жаль, при такій статистиці дуже великі питання, наскільки ця така героїчна хірургія у пацієнтів буде мати перспективу, як взагалі хірургічна стратегія. Тому взагалі по артеріальним резекціям на сьогоднішній день невідомий результат хірургічного лікування в плані позитиву на віддалені результати, дуже високий ризик проблем після хірургічного лікування і, можливо, потребує ще пошуку рідинна біопсія або вивчення, або інші маркери, предиктори, все ж таки, чи це пацієнти взагалі потребують розгляду можливості хірургічного лікування з точки зору покращення якості їх життя. Знову ж таки, ще одне дослідження, яке характеризує декілька типів артеріальної розповсюдженості пухлин при підозрі на артеріальну інвазію. Тип Б, він вважається на сьогоднішній день неперспективним з точки зору, навіть при можливості реконструкції, дає дуже погані віддалені результати, які майже не відрізняються при тих же самих результатах після неадювантної або самостійної хіміотерапії. Я хочу буквально декілька сказати слів про променеву терапію, яка на сьогоднішній день вважається достатньо обмеженою з точки зору можливостей в лікуванні рака підшлункової залози. Постійно йде вдосконалення апаратів для променевої терапії. Зараз ми використовуємо в інституті вже технології МРТ, технології прецизійного наведення, але американські колеги, які мають навіть більші можливості, такі як МРА, встроєні в лінійні прискорювачі і більш чітке наведення навіть, ніж лінійні прискорювачі стандартним КТ-наведенням, все одно мають певні проблеми і вивчають наступні питання. Наскільки може бути доза підвищена до дози аблятивної терапії для того, щоб лікування променеве впливало на віддалені результати. Так само вивчаються питання можливих препаратів, які підвищать ефективність променевої терапії. Це не хіміопрепарати, це препарати специфічні для радіосенсибілізації. А також вивчається питання, наскільки променева терапія може знижувати в рамках паліативного лікування ступінь больового синдрому. Звичайно, SBRT не впливає на віддалені результати. Вже є публікація потужних досліджень. Абляти доза починається з 85 греїв. Так само це проводять автори аналогію з дозою при раку легень. При раку легень також доза променевої терапії, яка покращить результати виживаності пацієнтів, починається з 85 грей при локальному раку. Це дуже важко досягти при раку підшлункової залози все ще, навіть при найкращих умовах в Сполучених Штатах. Ви бачите, 70 грей, а треба бажано 100 для ідеальної дози. На жаль, все ще дуже високий ризик отримання перфорації і ускладнень місцевих при підведенні такої дози до головки підшлункової залози, і ми не маємо техніки для прецизійного наведення. Да, є методики, ви бачите, різні 50 по 5, отримання 50 грей по 5 фракцій і так далі, але це не показало, на жаль, зараз трошки повернусь, не показало, на жаль, впливу на віддалені результати порівняно з самостійною хіміотерапією. На сьогоднішній день така доза терапії променевої під сумнівом з точки зору впливу на віддалені результати лікування. Тільки для того, щоб мати освіченість в тому, що відбувається в полі вивчення променевої терапії, ви бачите, є декілька препаратів, які вивчаються в різних режимах з променевої терапії з точки зору підвищення ефективності променевої терапії. Трошки є відмінність в медіанах по Каплан-Майеру від контрольної групи, яка отримує плацебо на променевій терапії. Є дуже складні протоколи застосування даних препаратів на різних етапах променевої терапії. Це все на сьогоднішній день висновок ще залишається зоною вивчення. Тобто певний отримано ефект початковий, але це не роки, це якісь місяці порівняно з стандартною променевою терапією в паліативному режимі. Ну і достатньо ефективною вважається променева терапія з точки зору зняття больового синдрому при неоперабельному раку підшлункової залози. Ви знаєте, що при локалізації проблеми в тілі або в хвості підшлункової залози основною скаргою пацієнтів для звернення до лікарів як у нас, так і за кордоном є больовий синдром. Це, як правило, вже інвазія пухлини в нервові сплетення і, відповідно, неоперабельність. Як правило, при цьому вже є віддалені метастази в печінку або в інші органи. І таким пацієнтам дуже важко підібрати протибольову терапію. Було декілька досліджень, які вивчали різні режими променевої терапії. Бачите, ціллю дослідження, наприклад, оцього 25 грей за один курс лікування, було досягнення хоча б у 40% пацієнтів ефекту, який дозволив би їм знизити дозу опіатів. І автори наголошують на тому, що вони змогли отримати завдання, бачите, чітке планування даної зони, режим опромінення. Якщо це буде цікаво для променевих терапевтів, вони в подальшому подивляться. І навіть в 53% випадків було досягнуто success rate по зниженню інтенсивності больового синдрому, зниженні, бачите, дози опіоїдів, які потребували пацієнти для зниження цих болей, які є дуже інтенсивними при раку, неоперабельного раку підшлункової залози. Отже, по медикаментозному лікуванню ми будемо говорити про медикаментозне лікування в світі 4-ї стадії рака підшлункової залози. Це, на жаль, основна група пацієнтів. Рев'ю по основним режимам, які на сьогоднішній день застосовуються, які дозволяють нам досягти в середньому від 6 до 11 місяців лікування. 97 рік з'явився монопрепарат гемцитабін, який дозволяв достатньо в гарному стані пацієнтам прожити в середньому 5,5 місяців. В подальшому з'явився комбінований режим гемцитабін з ролатинібом, який трошечки подовжив медіану тривалості життя до 6 місяців, 6 з чвертю. І один з проривів в 2011 році фолфірінокс комбінація, яка потім була трошки послаблена. Ця комбінація майже вдвічі дозволила більше жити пацієнтам з метастатичною формою рака підшлункової залози порівняно з першими спробами. Але ця комбінація достатньо токсична. В цьому дослідженні не більше 60% пацієнтів змогли отримати весь протокол лікування, який був запланований. Із-за того, що триплет, пацієнти в основному в віці з супутніми проблемами, перенести достатньо важко. Відповідно, в 2013 році достатньо непоганий по переносимості режим комбінації гемцитабіну з напаклітакселом дозволив таким пацієнтам отримати альтернативу більш токсичного режиму фолфірінокса. І вивчення різних препаратів, особливо в другій лінії, що на сьогоднішній день є дуже великим питанням, наскільки друга лінія при неефективності першої лінії або після подолання цього попереднього ефекту першої лінії терапії може бути ефективним, показав певну перспективу заміни іринотекана пігельованим іринотеканом, онівайдом, дозволило в подальшому вивчати даний препарат в рамках першої лінії терапії. І я вам хочу представити вже за той час, який в мене залишився, дослідження, яке презентувалось на ASCO 2023, вже дослідження на полі-3, пігельований іринотекан в комбінації з оксаліплатином і пептороцилом проти напаклітаксела з гемцитабіном. В першій лінії лікування пацієнтів з метастатичною формою рака підшлункової залози. Включені майже всі основні країни світу. Відповідно, достатня кількість пацієнтів для проведення статистичного аналізу – 770 пацієнтів. Ми тут представляємо протокол, достатньо стандартна схема, де був застосований ліпосомальний іринотекан. Вона майже така сама, як схема фолфірінокс, але ця схема дозволила вводити меншу, і було заплановано вводити меншу комбінацію оксаліплатина, який є один з токсичних агентів, з якими пов'язана основна токсичність в стандартному режимі. Ну і стандартна схема гемцитабіна з напаклітакселом. Primary endpoints були це відповідь на лікування, це медіана до прогресії пухлини і також медіана і загальна виживаність пацієнтів, відповідно. Другі цілі – це пошук біомаркерів, які б могли бути предикторами на відповідь і на прогноз даних пацієнтів, і токсичність. Відповідно, ви бачите розподілення пацієнтів по групам і комплаєнс, скільки пацієнтів змогли отримати лікування в запланованому режимі. Комплаєнс був достатньо високим, 85 і 96 відповідно в групі досліджуваній і в групі порівняння гемцитабіна з напаклітакселом. І не було статистичної різниці по основним показникам, таким як країни, локалізація проблем, локалізація пухлини, статус пацієнта по ЕКОГ. І саме цікаве, що нас хвилює в дослідженні, це порівняна виживаність. В цьому дослідженні також було отримано преваленс виживаності по групі досліджувань, де використовували триплет. Відповідно, ви бачите, медіана виживаності склала 11,1 місяць проти 9,2 місяців в групі контролю. І це дослідження було бенефішері по всім групам пацієнтів. Жодна група не виявила якихось відхилень в бік групи контролю. Відповідно, комбінація триплет із новим препаратом пігельованим іринотеканом показала переваги в порівнянні по підгрупам. Також триплет показав кращі результати при порівнянні медіани до прогресії хвороби. І знову ж таки, тут не було виявлено ніяких відмінностей при субгруповому аналізі по віку, по локалізації, по біомаркеру і так далі. Порівняння по одному з основних завдань по відповіді пухлини на лікування також показало об'єктив респонс більший в групі досліджуваній, де відповідь на лікування склала 41, майже 42% порівняно з 36% в групі контролю. Повних відповіді це по одному пацієнту відповідно до статистики, а часткова відповідь була значно більшою в групі, де використовували триплет. Далі це, можливо, запитання до співавторів. Вони не акцентуються на тому, чому було застосовано хірургічне лікування в групах. Можливо, це групи комплект респонсу, але це статистично дуже незначний відсоток, тому не так цікавий для нас. Але нам дуже цікаве питання з точки зору побочних ефектів. Відповідно, гематологічна токсичність, токсичність інтестинальна і інші види токсичності не відрізнялися в обох групах, тому можемо сказати, що і secondary endpoint був досягнутий в даному дослідженні, коли нам треба було знайти ефективну комбінацію хіміопрепаратів, яка по токсичності не відрізнялась би від тої, що була запропонована в 2013 році. Отже, у нас майже з 2013 року не було жодного позитивного дослідження, в тому числі і досліджень, присвячених імунотерапії, в тому числі і досліджень, присвячених таргетній терапії, які б давали якісь нам бенефіти в лікуванні рака підшлункової залози. Дана схема показала непогану відповідь і достатньо гарний профіль токсичності по всім напрямкам, як гематологічна токсичність, так і токсичність гастроінтестинальна. Відповідно, в висновках на сьогоднішній день ця схема розглядається як може бути потенціально рекомендованою в рамках першої лінії лікування рака підшлункової залози. Вона показала статистично кращі результати в плані загальної виживаності, токсичності, медіани до прогресування із таким самим профілем токсичності, як попередньо успішна схема, така як схема гемцитабін плюс напаглітаксел. Є певні, звичайно, питання, і в нас аудиторія питала, наскільки ця схема буде виправданою з точки зору фінансової токсичності. Я повинен про це сказати. Це новий препарат, він достатньо дорогий порівняно з попередніми, але, можливо, виробники в найближчі часи, в найближчі роки дозволять зробити цю схему більш доступною як для європейців, американців, так і для українців, тому що по онкологічним показникам вона на сьогоднішній день, можна сказати, що найкраща. Але є певні питання, які ще треба вирішити, і в тому числі одне з завдань – це віддалений аналіз виживності таких пацієнтів, прив'язаний до маркерів онкологічних. Можливо, це також напрямок, який дозволить більш широко рекомендувати дану схему лікування. Я вам дуже всім дякую за увагу. Якщо будуть якісь питання, будь ласка. У нас є наступний спікер на контакті? Да? Ми тоді будемо дякувати всім учасникам за увагу. У нас є в записі ще один наш спікер з Сполучених Штатів по спадковим синдромам в розвитку онкологічних захворювань. Дуже цікава лекція, ми її зараз включимо. Будь ласка, якщо будуть у вас запитання в чаті, пишіть нашим модераторам, ми на них дамо відповіді. Я всім вам бажаю здоров'я, нам всім швидкої перемоги, мирного неба. Дякую ще раз нашим американським колегам, хто приїхав до нас. Вам будемо бажати щасливої подорожі назад і будемо також вас дуже раді бачити тут у нас наступного разу. Добре, всім дуже дякую.
Hello, everyone, and thanks for having me today. I'd like to thank Dr. Portland for the invitation. My name is Mohammad Abbas. I'm one of the colorectal surgeons at Northwestern Medicine, and I'm planning to talk a little bit today about hereditary colorectal cancer and give you just a fast digest of what we know about those syndromes and some updates as well. As a baseline, we know that all colorectal cancer is genetic, which means it's a problem that starts at the genes of the epithelium of the colon, and this slowly develops into an adenoma or a precancerous lesion and end to cancer. It doesn't mean that all colorectal cancer is inherited or could be passed to future generations. 3 to 5% of colorectal cancer in patients older than 50 years old is inherited, while 16 to 20% in patients less than 50 years old is inherited. We know that this percentage also goes up to 35 to 40% in patients less than the age of 35 as well. 1 out of 279 people in the general population have a diagnosis of Lynch syndrome. So we think the syndrome is truly underdiagnosed in the general population. 1 out of 20 to 30 patients with active diagnosis of colorectal cancer do have a diagnosis of Lynch syndrome as well. When we think of how we take care of those patients, or what is our mission when we manage those patients, I always remember what my mentors taught me, and this was passed along from their mentors as well. Our goal is to prevent death from cancer while maintaining quality of life, which means you don't want to just prevent death from cancer and do some big operations on the patients where they can't live a good quality of life and enjoy the time they're living. You want to prevent them to die from cancer, but you also want to maintain a good, acceptable quality of life. Family history has always been important and plays a role not only in sporadic cancer, but also in inherited cancer. If you have one first-degree relative with colorectal cancer, that increases your relative risk of developing cancer twice more than the general population. And this increases to 2.5 times if you had a sibling with colorectal cancer. If you had more than one relative, this goes up to 4.25 times the general population. Family history also plays a very important role in hereditary colorectal cancer syndromes. When it comes to Lynch syndrome, Amsterdam criteria has been very important. We know that if you have 3 individuals with any Lynch syndrome associated cancer in 2 consecutive generations, and one of them less than the age of 50 years old, that means there's a 50% chance you would have a positive germline test for Lynch syndrome. In FAP, it's a little bit different. Of note, 20% of patients with FAP have de novo mutations, which means they don't have any family history of FAP at all. This is how hereditary colorectal cancer syndromes used to look like 2 decades ago. We used to think of it as polyposis and non-polyposis, dominant and recessive. Look at the type of the polyp, whether it's an adenoma or hematoma, and classify them based on that. Now things gotten a little bit more complicated. We have many other recessive polyposis syndromes that we think of. We have a lot of mid-level genes, which means those are genes that increase your risk of colorectal cancer. You can pass those genes to future generations, but sometimes you don't have a typical phenotype. When we think of management of those patients, there's no management without diagnosis. And I know from my conversations with a lot of colleagues in some countries outside the United States, there's a limited access to genetic testing, which makes your management a little bit more complicated. But we can always focus on family history because it's going to give you the highest yield, like we talked about Amsterdam syndrome and Amsterdam criteria and Lynch syndrome. Patients who are less than the age of 50 years old with an active diagnosis of cancer, those are patients we need to investigate. Patients that have a mismatch repair deficient cancer, we also need to investigate those. And patients that have more than 10 adenomas cumulative over their lifetime. When we look at FAP, which is the most common polyposis syndrome, when do we start our surveillance and when we do surgery? Surveillance starts at age 10 to 12, and surgery usually is planned in the United States after high school, which means the patients are 17 or 18 years old. We only can do surgery at 18 years old if the patients did not have an active diagnosis of cancer before that. They did not have an overwhelmingly fast-growing number of polyps over every colonoscopy we're doing, and they don't have high-grade dysplasia. We looked at 26 registries with 22,000 families. We had 14 cases of cancer in the age less than 20. Only one of those was less than 15 years old. And that's what gives us the ground to say we can wait till after high school. When we look at the type of surgery, we usually try to spare the rectum because any patient that has the rectum intact versus an early renal anastomosis, they're going to have a better quality of life. We looked at 116 patients. This is an old study from Cleveland Clinic. 33 patients had less than 20 polyps in the rectum, and we noticed that once we gave those patients an ileorectal anastomosis, they had a complete resolution of their polyps after surgery, which built the basis of a phenomenon called rectal polyp regression, there's really no way that we can prove how that happens or why that happens. And there's a lot of recent discussion about that, but this is something that's noted in all polyps in the rectum, but mostly notable in patients that have less than 20 polyps. In the United States now, 20 is not a fixed number. If we're able to manage those polyps endoscopically, we'll do another rectal anastomosis in a higher number of polyps. Desmoid risk. Desmoid risk is based on some genotyping and some phenotyping criteria. Genotyping, we notice that patients that have a germline mutation at the 3' end of the gene or at the 1309 location, those are patients that are more prone to develop desmoids. If you don't have access to genetic testing, we notice that patients with FAP that are more prone to develop desmoids are patients with female gender, have a positive family history of desmoids, and have extracolonic manifestations of FAP. So how do we manage patients with FAP? Number one, the first question we want to ask ourselves is, what is the rectal polyp burden, and can that be managed endoscopically or not? If it can be managed endoscopically, great, then we can do a total colectomy and an ileorectal anastomosis. If it cannot be managed endoscopically, then those patients need a total proctocolectomy. When you do your total proctocolectomy, now you're doing an ileoanal anastomosis. You want to look at your anal transitional zone. If there are no polyps there, then you can land a stapler, so we can do a stapled anastomosis. If there are polyps present at the ATZ, then we can't do a stapled anastomosis. We have to do a hands-on IPAA, which means you have to do a mucosectomy as well. We know also that patients that have a stapled ileal pouch anal anastomosis have a better quality of life than when they have a hands-on anastomosis. Lynch syndrome. So Lynch syndrome is the other most common non-polyposis colorectal cancer syndrome. It's present in 1 out of 279 of the general population, and it's present in 1 out of 20 or 30 in patients with an active diagnosis of colorectal cancer. There's a risk of constitutional mismatch repair deficiency in children of patients that have Lynch syndrome, which means either both parents have an active diagnosis of Lynch syndrome and they pass each mutation to their next upcoming generation, which means they've got a copy from the mom, copy from dad, and they could be sick. Or it means that the patients have inherited one copy from their parents and they've had a mutation while they're during pregnancy, and then they developed what we call a constitutional mismatch repair deficiency. We always focus on genotype and phenotype-based management. Long time ago, we used to talk about extended surgery in patients with Lynch syndrome, but now we also look at the family history as well. Screening interval, this has always been a very interesting question. This is data that came out from the prospective Lynch syndrome database from Europe. They looked at 209 patients with Lynch syndrome. Those had 218 cancers. They looked at interval colonoscopies of less than 1.5 years, 1.5 to 2.5 years, 2.5 to 3.5, and more than 3.5 years. What's fascinating is you would think if you look more, you're going to save more patients. And if you leave the patients for a longer period of time, you're going to find more cancers. The opposite was true. They noticed that the highest number of cancers found were at patients in the 1.5 to 2.5 year interval. And they found less cancers when they left the patients for 2.5 and 3.5 years or more than 3.5 years. The author's conclusion was fascinating for this paper. They said that frequent surveillance does not increase detection. Great. But they also raise a question that frequent surveillance is probably harmful to this population because you're detecting more cancers that might have been cleared by the immune system. And now that we know that the immune system is very involved in patients with Lynch syndrome, this might be true. And this data looked at a risk of any colonic neoplasia after a proctectomy. So you have a patient with Lynch syndrome, they had the rectal cancer, you did a proctectomy on them. We looked at 50 patients. Those patients had rectal cancer. 13 of them had high-risk adenomas. 15.2% had metachronous colon cancers. So overall, 51% of those patients developed some kind of neoplasia in their left colon, which means you can't leave those patients alone. After they develop their index cancer, you have to keep a closer eye on them. Now looking at patients that had segmental resection versus extended resection. Segmental means they've had an oncologic resection of their cancer, and extended resection means they've had an extended colon resection. We had 296 patients, 253 had segmental colectomy. Out of those, 222 had ongoing surveillance, Out of those, 25% of patients developed metachronous colorectal cancers, versus the patients that had total colectomy or extended resection, only 8% developed metachronous cancer. So you're decreasing your risk of metachronous cancer in the future from 25% to 8% with extended resection. Now, of course, we know we didn't have genotype data or phenotype data when the study was done. So we know now things could be a little bit different. This was a good study because it looked at defining the adenoma burden in Lynch syndrome. We used to call patients with Lynch syndrome hereditary non-polyposis colorectal cancer patients because we thought that the phenotype did not have polyps. Well, this paper looked at patients with Lynch syndrome. They looked at 263 patients. 107 of them had more than one adenoma. 29 had 2 to 5, and 11 patients had 10 or more cumulative adenomas. The maximum number of synchronous adenomas was 22 and cumulative was 24. So although 10 or more adenomas raises concern for polyposis syndrome, we still also have to think of Lynch syndrome. This is just highlighting the importance of surveillance when we look at those patients. So remember, the risk of cancer is high, but we still don't know how often we need to survey them. And now we also know that probably frequent surveillance might be harmful to those patients, but we also can't let them go. And this has built the basis of a lot of other studies that looked into the origin of cancer and Lynch syndrome. The discussion goes on to say, do those cancers develop from polyps or do they develop from flat lesions, which you cannot see endoscopically? The era of immune therapy has opened our eyes to a lot of important factors in Lynch syndrome. When Amsterdam criteria came along, we used to have something called Bethesda criteria, which used to raise the flag when you see lymphocytic infiltration in tumors that this could be related to HNPCC or Lynch syndrome. And now, knowing how immunotherapy works and the activation of the immune system in Lynch patients, we think this is a very valuable thing to use to our side. Dr. Shalaby looked at immunotherapy in the setting of colon cancer. So she looked at patients with microsatellite unstable or high colorectal cancers and treated them with immunotherapy and then went to surgery after. And they noticed that major pathologic response was noted in 95% of patients. 67% of them had complete pathological response. Also, this is a recent paper, which I'm sure most of you have heard of. It came in the New England Journal of Medicine late last year, almost a year ago from now, looked into the neoadjuvant treatment of patients with rectal cancer with MSI-high tumors with immunotherapy. And it's showing us a complete resolution of the tumor. In this paper, they had 100% response to immunotherapy. Chemoprevention is also a new development in patients with Lynch syndrome. This is Sir John Byrne, who has been running a trial called the CAP trial, now on their third iteration. They looked at the effect of aspirin on the risk of cancer in patients with Lynch syndrome. They looked at 861 patients from 43 countries. They had 600 milligrams of aspirin daily, and they had up to 20-year follow-up on those patients. They noticed that 9% of patients in the aspirin group developed colorectal cancer, compared to 13% in the placebo group. Although they said that their conclusion did not reach significance, but the protocol analysis showed significantly reduced overall risk in the aspirin group for patients to develop colorectal cancer. Now they're looking at dose-specific effects of aspirin on the risk of on the future risk of cancer. The era of anti-cancer vaccine has come along. There are multiple groups that are working on vaccines that could be used in patients with Lynch syndrome. There was a phase 1 trial that looked at recombinant adenovirus-based immune therapy vaccine that had CEA, MUC1, and brachyuria markers. All 3 markers would be given at the same time. Those patients would get 3 doses. The first phase 1 trial that was run on 10 patients who had advanced cancer, they had no major adverse events. They had antigen-specific T cells to MUC1, CEA, and or brachyuria were generated in all those patients. Now, Dr. Villar-Sanchez and Dr. Bansal are running their phase 2 trial of that vaccine. The inclusion criteria for that trial is having a diagnosis of Lynch syndrome, proven by mutation, having more than one adenoma in your history, if you had an MLH1, MSH2, EpCAM, or MSH6 genotype, or if you're a PMS2 patient and had a history of cancer and a segmental resection where there's a leftover colon or rectum that we can survey. This is a very exciting trial that's undergoing right now. Of course, when we have limited access to genetic testing, we still go back in time and we focus more on our universal screening and try to conclude if patients do have Lynch syndrome or not. The most important feature we look at is seeing if those patients have a mismatch repair deficient tumor. This is a complex pathway that we look at the specific protein that's deficient on pathology, and we try to conclude, does this patient have a sporadic cancer or possibly a Lynch syndrome? The thing that to be noted here is not all patients that have a mismatch repair deficient tumor do have Lynch syndrome. Your options are either an MLH1 hypermethylation or having truly Lynch syndrome or having a phenomenon we call a double somatic mutation. When we look at all patients that have an MSI high colorectal cancer, patients that do not have Lynch syndrome, they could have something we call a double somatic mismatch repair pathogenic variant, which means your tumor have lost the two alleles that work on the mismatch repair process. That's why your tumor looks like you have Lynch syndrome, but you truly don't have Lynch syndrome. When we take all MSI high cases, we notice that 75% of those are due to hypermethylation, 10% of them are due to Lynch syndrome, and almost 10 to 15% are due to the double somatic mutation. Thank you for taking the time to listen to my talk. If you have any questions, please feel free to reach out to me via email or via Twitter, and I'm more than happy to help and walk you through.
Колоректальний рак є третім по поширеності у чоловіків і другим у жінок у світі. В 2020 році зареєстровано понад 935 тисяч смертей від колоректального раку, що становить 9% від всіх смертей від раку. Початково пухлина виникає в слизовій оболонці товстої кишки. Потім вона поширюється на всі шари товстої кишки і досягає кровоносної та лімфатичної систем. Дисемінація ракових клітин призводить до розвитку метастазів в різних частинах тіла. До складу лансурфу входить трифлоридин, FTD, і типірацилогідрохлорид, TPI. Трифлоридин є тимідиновим аналогом нуклеозиду. Типірацил є інгібітором тимідин-фосфорилази. Активним протипухлинним компонентом є трифлоридин. Молярне співвідношення 2 до 1 забезпечує оптимальну концентрацію трифлоридину в плазмі крові. Складність в тому, що після перорального застосування трифлоридин швидко розпадається в печінці до неактивних метаболітів під дією ферменту тимідин-фосфорилази. Через це до складу препарату було включено інгібітор тимідин-фосфорилази типірацил. Типірацил запобігає швидкому розпаду трифлоридину і різко збільшує його концентрацію і біодоступність. Попадаючи в кровообіг, лансурф діє на вогнища колоректального раку в різних частинах тіла. Давайте подивимось, як він працює на мікроскопічному рівні. Після проникнення в ракові клітини трифлоридин проходить 3 фази фосфорилювання. Спочатку він фосфорилюється з тимідин-кіназою, потім метаболізується в субстрат ДНК. На відміну від лансурф, 5-фторурацилова група препаратів утворює зв'язок з тимідилат-синтезою, що пригнічує утворення тимілату, необхідного для синтезу ДНК. Давайте розглянемо механізм дії лансурф. Після попадання в нуклеоплазму через ядерну мембрану трифлоридин-трифосфат вбудовується безпосередньо в ДНК ракових клітин, заміняючи тимідин під час реплікації. Це порушує функцію ДНК, призводить до зупинки клітинного циклу та запобігає проліферації ракових клітин. Рак шлунка – 5-й по поширеності і 3-й вид раку у світі за показником смертності. З 2020 року в Україні лансурф показаний в якості монотерапії для лікування дорослих пацієнтів з метастатичним раком шлунка, в тому числі пацієнтів з аденокарциномою гастроезофагенального переходу. Механізм депонування препарату Онівайт. Злоякісні пухлини підшлункової залози безумовно важко піддаються лікуванню. Пухлини підшлункової залози мають щільний шар десмопластичної строми, що стимулює ріст злоякісних пухлин та їхнє проростання. Погана васкуляризація перешкоджає надходженню кисню, поживних речовин і хіміотерапевтичних препаратів. До того ж, хронічне запалення довкола строми сприяє залученню імуносупресивних пухлиноасоційованих макрофагів або ПАМ та Б-клітин, які знижують протипухлинну імунну активність. На сьогодні загальний прогноз при злоякісних пухлинах підшлункової залози є дуже невтішним. Незважаючи на відносно низьку поширеність, злоякісні пухлини підшлункової залози займають 5-те місце серед причин смерті внаслідок онкологічних захворювань у Європі. Прогресування після терапії першої лінії в основному є неминучим у пацієнтів з пізніми стадіями злоякісних пухлин підшлункової залози або метастазами. Не існує визначеного терапевтичного режиму для пацієнтів, які зазнали прогресування після початкового лікування, що показує термінову потребу в наявності більш ефективної та краще переносимої терапії. Нещодавно в Україні був зареєстрований препарат Онівайт – пегельований ліпосомальний іринотекан. Онівайт був створений з метою підвищення депонування іринотекану в пухлині, шляхом подовження часу циркуляції в плазмі крові та стимуляції переважного захоплення пухлино-асоційованих макрофагів. Наночастинка Онівайт складається з пегельованого ліпідного подвійного шару з інкапсульованим іринотеканом всередині. Іринотекан – це інгібітор топоізомерази 1, що широко використовується при різних типах солідних пухлин. Іринотекан – це проліки. Він перетворюється в активний метаболіт СН38 ферментами, які називаються карбоксилестеразами. Як вільний іринотекан, так і СН38 швидко виводяться з організму. Ліпосома Онівайт підтримує низьке pH середовище, що захищає іринотекан від передчасного перетворення в СН38, а також від гідролізу в його інактивну карбоксилазну форму. Порівняно з вільним іринотеканом, Онівайт продемонстрував 40-кратне подовження часу напіввиведення у ході клінічних досліджень. Пегелювання ліпосом стабілізує Онівайт та подовжує циркуляцію шляхом попередження зв'язування з білками сироватки, що стимулює фагоцитоз циркулюючими макрофагами. Пегелювання також мінімізує агрегацію ліпосом, що може допомогти їм уникнути впливу розмірозалежних механізмів виведення. У ході доклінічних досліджень Онівайт продемонстрував переважне депонування в місці розташування пухлини внаслідок підвищеної проникності судин пухлин. Діаметр ліпосом Онівайду дозволяє проникати через такі судини. Екстравазацію ліпосом Онівайду до пухлинного мікросередовища та затримку внаслідок поганого лімфатичного відтоку. Пухлино-асоційовані макрофаги поглинають ліпосоми Онівайду у місці розташування пухлин та вивільняють іринотекан. Карбоксилестерази, що знаходяться в пухлино-асоційованих макрофагах та пухлинному середовищі, конвертують іринотекан у СН38. Переважне захоплення Онівайду клітинами пухлино-асоційованих макрофагів призводить до значно вищої концентрації СН38 в пухлинах порівняно з плазмою. У доклінічних мишачих моделях пухлин, взятих від пацієнтів, включаючи пухлини підшлункової залози, дослідили, що посилена СН38 експозиція внаслідок введення Онівайду пригнічує ріст більш інтенсивно, ніж іринотекан. Враховуючи це все, та дані результатів доклінічних досліджень з Онівайдом призвели до проведення міжнародного рандомізованого дослідження фази 3 під назвою Наполі-1 з метою визначення ефективності. Результати цього дослідження були опубліковані в журналі The Lancet 6 лютого 2016 року. Онівайт був визнаний частиною комбінованого режиму лікування разом із 5-фторурацилом та лейковорином.
Шановні колеги, ми можемо продовжувати із нашою наступною сесією «Системна терапія пухлин верхніх відділів шлунково-кишкового тракту». І я хочу вам представити лікаря-онколога із Massachusetts General Hospital Samuel Klempner. Він є спеціалістом у системній терапії стравоходу та шлунка. Працює у Бостоні, штат Масачусетс. Hello, Sam. We welcome you. In Ukraine, you're online, and I already introduced you. So yeah, you can start with your talk.
Perfect. Thank you very much, and thank you for the kind invitation. Someday I would love to be able to come in person. So I'm going to talk about managing non-metastatic gastric and GE junction cancers. Here are my disclosures. So I'm going to start by walking through the current standards and then really chose to focus a little bit on the evolving role of immunotherapy in non-metastatic gastroesophageal cancers, because certainly a hot topic and a common question from patients. I think if we really take a step back, at least I think many of us are coming to realize what a heterogeneous disease this really is. So outside of a couple small subgroups where it's very clear that the biology is different, such as MSI and HER2, we peel off and the management strategies are different. We largely lump everybody else together, and this is quite a mixed group of patients: Claudin, MET, EGFR, FGFR2, etc. And these groups of patients actually each have their own intrinsic biology of the disease, but we're treating them all similarly. So the big picture and theme of this talk and probably the next few years of gastric and esophageal cancer is really teasing apart these groups and ultimately exploring whether we need to manage them differently. As we know, most of our patients die of recurrent disease, and most of the recurrences for non-metastatic cancers are distant. People are not dying of local recurrences for the most part. The assumption is that pre-existing micrometastatic sites are the source of most recurrences, and when we're operating, it's not that our surgeons are not getting good resections and R0s and everything. It's just that there is underlying disease that we are unable to appreciate. If that's true, then better systemic approaches might improve micrometastatic eradication, and that, if it's truly eradicated, would ultimately translate into a greater sense of cure. And that's really where improved biologic therapies, if they work, will have their role. So the current tools we have this is not news to anyone here in the audience, but broadly can be broken down into local therapies, which are radiation and surgery, and systemic therapies, which are chemotherapy, and we have nivolumab approved in the US and EMA for adjuvant therapy after prior chemoradiation and surgery with residual disease. And this is really not a very big toolbox if we think about it compared to some other tumor types, but this is what we have to work with, and then there are, of course, nuances within these things. It's really important to understand our standard therapies, and FLOT is probably the most modern standard that is still the benchmark for many of our studies. So important to review. So interestingly enough, this is the data from the FLOT4 trial. We saw that this intensive 3-drug perioperative approach improved survival and disease-free survival over the prior standard, which was perioperative MAGIC. We saw really improvements across everything that was examined. Improvements in R0 resection rates. We did not see this come at an increase in surgical mortality. FLOT does have some additional toxicities, as everybody knows. And then we saw really some suggestion of increased biologic activity reflected in a pathologic CR rate. And so one of the, I think, assumptions and that will be tested is whether or not a path CR from a chemotherapy only or a non-radiation containing regimen really means that what you're seeing at the local tumor is what you're seeing at the metastatic sites. That's the assumption that if the primary tumor is responding, then presumably any micrometastatic disease may also be responding. So a path CR after chemo should therefore be associated with a very good outcome. And FLOT did improve the path CR rate versus ECF. And these are numerically the longest disease-free and overall survivals we have to date. And I just show them here on the left, as well as the general patient breakdown. This is pretty typical of a Western population, same patients that we would see that you would see. Checkmate 577 has been the most other recent addition, and for the sake of completeness, warrants brief discussion. So this was adjuvant nivolumab after preoperative chemoradiation containing approaches. So every patient had prior chemoradiation followed by a complete resection, and then everyone had to have some degree of residual disease, whether this was N positive or any T residual disease. And then they're randomized 2-to-1 to adjuvant nivolumab. So again, you're basically giving more systemic therapy versus placebo. The idea that if there's any residual disease, this active systemic therapy may mop that up, let's say. And then the primary outcome here was disease-free survival with secondary of overall, which we have yet to see. So this was an approved therapy published in the New England Journal, as you all know. There was essentially a doubling in the disease-free survival from 11 to 24 months. I think it's a sobering reminder that we really don't do very well in these high-risk patients without any additional therapy. 11-month disease-free survival is quite poor. The addition of nivolumab across this very mixed group of patients did improve the recurrence disease-free survival. And you see the squamous cancers perhaps are getting greater benefit than adeno. But the point here is that nivolumab is really systemic therapy. So in my mind, what they were asking is, if we give more systemic therapy, do we get better outcome? Or if we give better systemic therapy? And at least a suggestion towards yes. There's also a notable reduction in distant recurrences as well as local regional recurrences compared to placebo. And I don't think that's a big surprise, but what you would want to see. So that there had been a longstanding question about, FLOT versus cross. Everyone who's been to any conference has seen some form of this debate by various people. Neo-Aegis was an effort and a well-intended effort to sort of provide some data around this question. It wasn't really FLOT versus cross. It turned out to be mostly MAGIC versus cross. There's a small amount of FLOT mixed in there, which I'll show you. But really an important trial to sort of gauge whether or not greater systemic therapy may truly be a path towards greater success. At least from what we've seen, and again, here you see is only about 15% of patients got FLOT. This is a real world population. These are the patients we see. A lot of T3 tumors, a lot of node positive disease. But at least in this approach, cross was non-inferior to perioperative, primarily MAGIC. So if we think back, FLOT is directly better than MAGIC in head-to-head comparison. So it's hard to extrapolate a little bit, but this is the comparison that was made. There's no difference in survival. And just for context, I put the 3-year OS from the FLOT 4, both for FLOT and for the control arm. So interestingly, the perioperative chemotherapy in Neo-Aegis did a little better than the perioperative chemotherapy from FLOT. And it may just be that we're getting better at taking care of these patients. So what about trying to leverage the potential advantages of both strategies? Why not give someone the benefit of systemic chemotherapy with an active systemic regimen like FOLFOX, and then give them the potential advantages of a local therapy in improving R0 resection rates, etc. And this was a very interesting study that took a PET adapted design. So patients either got induction FOLFOX or induction carbotaxol. After about 36 days, they got a repeat PET. And then if there was a PET response, as in greater than 35% reduction in SUV max, then they were continued on the same systemic therapy as the backbone for their chemoradiation. And at least there's a suggestion that numerically there was higher response rates to FOLFOX, so maybe a more active systemic therapy, but that was not technically statistically significant, nor was it a primary endpoint of the trial. Interestingly, if you respond to PET, you do better. No big surprise there. And then among the subgroups, the people that did the best were the people that arguably got the most active systemic combination, which was FOLFOX, response to FOLFOX followed by FOLFOX RT. And that 5-year overall survival rate is quite good. So doesn't really compare the two strategies head to head, but at least offers some data about this induction followed by chemoradiation approach. that's really the background. And now I'm going to dig into the evolving things that impact our management. So MSI is a very low-hanging fruit. Everyone's aware of this. It's about 7 to 20% of non-metastatic patients, and I just put the big data sets up here on the right. And then in the metastatic setting, it's a lower frequency, somewhere in the 3 to 5% of patients. We know that these tend to be older patients. They tend to be intestinal patients. They tend to be, if anything, maybe a little bit more women than men. But why does it matter? So in stage 2 and 3 patients, similar to colorectal cancer, MSI high patients just do better. So this is a large meta-analysis from JCO a couple of years ago that just showed if you just take MSI high versus non-MSI high, the MSI high patients do substantially better. So 5-year disease-free and overall survival in the 70s versus in the 50s for the MSS patients. But what really comes to drive home the point that we need to think about managing these patients differently was this observation. And the next speaker was involved in this, Dr. Lizzy Smyth. And so this was a suggestion, and in my mind, quite compelling data. It's probably the largest data set we're ever going to see. And really what they demonstrate is that the MSI high patients, whether they were given adjuvant chemotherapy or perioperative therapy, they really did not benefit from this approach. And this sets up a scenario where we should strongly consider either upfront surgery for this population when we're not going to be giving them benefit from chemotherapy, or more importantly, should we consider immunotherapy-based approaches, which that's the new data I'm going to show you in a few minutes. There are a couple caveats. So FLOT was not included in this retrospective. So we don't know if the best systemic therapy might overcome this. We could debate about that. And so this is a little bit heterogeneous. That's a fair criticism. So most of our patients need systemic therapy, basically anyone greater than a T1 tumor. Trials whenever we can. FLOT is active systemic therapy. It's our preferred approach to GE junction gastric cancers when patients are candidates. We reserve radiation primarily for esophageal cancers or earlier stage disease, and of course squamous. And then it's really important to identify upfront the MSI high population, because those are people that maybe you could spare them toxic chemotherapy. Maybe they benefit from surgery alone without the need for anything else. But we really need to test everyone. That's probably the main point of part 1. All right, so let's move into the IO world. So why do this? So this is a very, I thought there's a million papers and reviews and everybody wants to get their figure out there somehow. But this is a nice one a couple of years ago from Nature Medicine. So the idea, as you know, historically, gastric esophageal cancers, upfront surgery had played a major role, and it still does in many parts of the world. In that idea, the bulk of the tumor has been removed. So the source of antigens for the immune system to react against has been removed by our surgical colleagues. And in theory, the only thing that's left is micrometastatic disease that the surgeon could not see and scans did not pick up. So if you give immune therapy in that setting where there is very low burden of disease, there's just few antigens to stimulate an anti-tumor immune response. So you get a less diverse and perhaps a less durable anti-tumor immune response from checkpoints when the tumor is out. Clearly, we've seen some data that this may still be enough to drive some benefit with Checkmate 577, but really the field is moving more towards the idea that what about giving the checkpoint inhibitor when the primary tumor is still intact and there is the full complement of tumor antigens for which the immune system could react against? Here, when you stimulate or relieve negative checkpoints, the hypothesis is that you get a much more diverse and persistent immune response. And there is some very nice preclinical models in breast cancer to support this. And there is also some very nice data in melanoma suggesting, this is a very recent New England Journal paper, that if you only difference between the two groups, if one gets neoadjuvant pembro, both groups get adjuvant pembro, the disease-free survival was dramatically better in the people that got the neoadjuvant component. So the only difference there was the neoadjuvant component. So it's sort of clinical support for this argument. But what about our patients? And so this was really the first prospective data that was done to any scale. There had been some nice retrospective suggestions of this, but this was the Neo-Napiga trial. Very nicely done French cooperative group study where they took patients who were MSI high. They had locally advanced GE junction and gastric cancers. This is a Western population. They basically took the same rationale and said, let's give neoadjuvant IO. They gave neoadjuvant ipi-nivo for 3 months. Then patients had surgery, and then they got adjuvant nivolumab. So basically to complete a total year of therapy. The primary endpoint was path-CR. It's a nice primary endpoint. It's readily accessible. It's quick, although as we can talk about, it may not be a perfect surrogate for cure. But suffice to say that they showed a very encouraging pathologic complete response rate of about 60%. And almost 80% of people had a major pathologic response, so TRG 1 or 2. So this was, if you compare that against what you might expect for chemotherapy, maybe in the 15, 20%, and probably even lower for MSI, which is kind of intrinsically 5FU resistant, this was really strong support for the idea that in well-selected patients, if we give the right drugs, we can do quite well. Of course, these are not a lot of follow-up, but if you look at the curves in the bottom right, you see that basically nobody has died or recurred. And I believe the one person who is the censoring there died from something else or recurred, met it out during therapy, and then died from another cause. As you can see, there's only one event out of the patient population. So this are curves we would love to see. This was sort of validated at ASCO GI just about 6 months ago in the Infinity trial. This is an Italian design trial. And so here patients only get neoadjuvant therapy. There's no adjuvant immunotherapy here, but durvalumab and tremelimumab, another CTLA-4 and PD-1 combination. And you see that there's about 3 months of preoperative therapy and then surgery. Cohort 1 is what I'll show. Cohort 2 is really interesting. This is asking a question saying, okay, so we've got a really active biologic combination that has a very high response rate, like 60% path-CR rate. Can some of those patients get away without surgery? And that is an ongoing question and a very important one. In the bottom left here is the waterfall plot. And what you see is basically there's a very high path-CR rate. You can see a lot of those bars go all the way down to 100% tumor decrease. This is shown sort of numerically in the table in the middle of the slide. And then over on the right is the characteristics. One thing that did pop out of this, and again, numbers are extremely small here, is that T4 tumors, so really locally advanced tumors, seem to have lower rates of path-CR in this very small data set. So something to keep an eye on as we see the field evolve for this. So that brings us to sort of first new management is really the MSI high patients. So our institution and many institutions, probably many of your own as well, when we see a localized or locally advanced patient, we do MSI testing for everybody. We then have a discussion at our tumor board, and Dr. Patsko was present for a few of those. It was a pleasure. We discussed with our surgeons, discussed with our rad onc, and then increasingly we are moving towards upfront surgery for patients that either decline or are not good candidates for immunotherapy-based approaches. If we have a trial, of course, that's the preferred choice. But even off protocol, I'm increasingly giving preoperative immunotherapy containing regimens. And granted, in the US, we can perhaps do this a little bit easier than other parts of the world, and that's not lost on me. But I think this is an emerging strategy. All right. What about the 90% of the rest of patients who are not microsatellite high? So this is the newest data, which I'm going to walk through in the last 10, 15 minutes. So this asked a very straightforward question. So as you know, in much of the world, particularly in Asia, when a new locally advanced gastric cancer presents, upfront surgery with very, very good surgeons has been associated with very good outcomes. They do very well with surgery and adjuvant therapy. So they asked the question about what if we just add immunotherapy on top of our sort of standard adjuvant chemotherapy. So these were stage 3 patients who underwent a D2 resection, R0 resection, healthy enough to get adjuvant therapy and had tissue. Investigators were given the choice of the standard options in Japan, Korea, Taiwan, and China. So CAPOX are S1, and these had been validated in prior phase 3 trials. They were given nivolumab every 3 weeks with their chemotherapy or placebo. And the primary endpoint was recurrence-free survival. You can see that in the Nivo arm, patients got up to a year if they were S1 containing, or 6 months if it was CAPOX. That's just the standard duration. Here's the patients that went on. This is a very typical Eastern population. You see most patients from Japan and Korea. You see this is the vast majority of gastric cancer, only about less than 10% GE junction cancers. They're all stage 3 patients, as I said. Most people had a distal or total. There are very limited other types of surgical approaches. About 80% were tumor cell PD-L1 negative. So this is not CPS, this is more TPS scoring. And you can see that there's about 2-to-1 breakdown for CAPOX over S1 in terms of the chemo choice in both arms. Unfortunately, this was a negative study. So the median recurrence-free survival was not reached in either arm, but in the 3-year, which was their duration of follow-up planned, you can see both arms did quite well. 65% of patients alive in the placebo chemo arm and 68% alive without recurrence in Nivo plus chemo. So really no definite signal here. And there's some subsets that have not yet been presented, like what about the impact of PD-L1 expression? Were there MSI high patients in here? Can we kind of dig into this data a little bit more? But at the current high level, there is not support for adjuvant chemo IO for all comers after surgery for gastric cancer. Dr. Smith and the EORTC asked a very practical and very important question that was just presented a couple of weeks ago. And thanks to Dr. Smith for providing me these slides. This is from ESMO GI just at the end of June. So probably one of the more common questions that come up at our tumor board, probably same as your tumor board, is, okay, we gave this person FLOT, we took them to the surgery, and they had no pathologic response, and they have, 8 of 25 nodes left over and a T3 tumor. Are we just going to give them more FLOT? That seems like not the right thing to do. But of course, that is the standard thing to do. So what if we gave them some totally non-cross-resistant approach? What if we gave them adjuvant Ipi-Nivo? You could ask the same question if you gave them adjuvant irinotecan-based therapy, for example. But obviously, there was a lot of inertia and rationale to think about adjuvant IO. So this was a very practical trial. Patients got surgery. These were patients who had an R0 or an R1 resection and or had residual node-positive disease. So high-risk population, randomized 1-to-1 for control arm, which was the post-op chemo, so the standard of care, versus the experimental, which is our sort of standard Ipi-1, Nivo-3 dosing. And then they were followed for disease-free survival as well as the secondary endpoints there. This study was terminated early by the Data Monitoring Committee for futility, and you'll see why here. So in the population, you see that it's about 60% gastric, about 30% GE junction, and there's a smattering of CWERT1 lower esophageal cancers. You can see that it's a pretty even split between intestinal and other, and that of course includes our diffuse type patients. You see that basically the vast majority of people here were node positive, and the R1 resection rate was about 16%. And that's actually well in line with FLOT. I think some of us at our high volume institutions, our institutional R1 resection rate may be lower than that, but in real world population, these are numbers that are very consistent. So this is a very practical patient population and data set. You can see that most people got through all the planned neoadjuvant chemotherapy, which would generally be about 2 months, so 8 weeks here. And then what is shown here in the upper right is the primary endpoint from the data that was available. And this is not what you want to see for any of our trials, but it's very important data. And so you see the experimental arm in red doing significantly worse than the control arm in blue. And if you look at the numbers, you see the median disease-free survival about a year in the Ipi-Nivo and about 2 years in the chemo-containing arm, and that's shown in the tables below as well. So this offers a very strong suggestion that adjuvant ipi-nivo for all of these patients when they come in the door with residual disease is not the answer. Are there subsets that may be teased out? Certainly, and Dr. Smith and her team have continued to analyze this, looking at PD-L1, gene expression data, MSI status, etc. So there probably will be some small subgroups that maybe be considered for this strategy, but certainly not a fit for everybody. So what we've talked about so far is adjuvant immunotherapy. Let's talk about perioperative immunotherapy for the rest of the patients. This is the Dante trial, and the primary endpoint here was disease-free survival. This is a phase 2 study. And really what they've shown here in the early reporting is that adding immunotherapy on top of standard FLOT chemotherapy improves the pathologic CR rate, particularly in patients who are PD-L1 positive. So that makes total sense. If you select patients for the biomarker that we have, which is PD-L1, you add a drug that's active in that population, you should see increased activity. That's exactly what we've seen. But does it mean that it's going to apply to everybody? So this is data from just about a month ago at ASCO. This is a phase 2 trial from Asia, looking at a very similar question, perioperative chemotherapy plus immunotherapy. So these were gastric GE junction patients, primarily stomach, who are resectable. You see that they stratified by histology and location. And toripalimab, in this case, was the experimental drug. And this was perioperative SOX or ZLOX. And you can see it's about a 100-patient trial. The primary endpoint here was pathologic complete response. Here are the patients that went on study. You can see that, again, this is about 2/3 gastric, about a third GE junction, about a third diffuse type. So relatively representative of sort of patients that we would see. Here you see the R0 resection rate is high 90s. And that's more typical of Asian trials in general. The primary endpoint is shown up in the upper right with highlighted in red. You can see that the overall pathologic complete response rate was improved, as was the major pathologic response rate, which is when you combine, TRG 0 and 1. And this was statistically significant. So all we can really conclude is that the addition of PD-1 to chemo increases the path CR rate, does not negatively affect the surgical outcomes or R0 resection rates. There is not a clear increase in adverse events. This trial did not yet present any of the breakdowns that you would want to see immediately, which is it the PD-1 patients who are driving this improved response rate? Are there a bunch of MSI high patients seen here? And of course, do we cure patients and reduce the risk of recurrence? So we haven't seen any of that data. So all we can say is that improving biologic therapy in the neoadjuvant increases path CR rate. That was timed very closely with 2 updates from 2 phase 3 trials, which potentially could impact practice. The Matterhorn trial is a very clean, very straightforward question of modern standard of FLOT, question of adding perioperative durvalumab. There you can see the primary endpoint is event-free survival and secondary endpoints are path CR. This is a primarily Western population, but is a global trial. And you can see it's also stratified by nodal status and PD-L1 expression status. In June last month, we saw a press release saying, very similar to what I just showed you with the phase 2, that the durvalumab containing arm had a statistically higher pathologic complete response rate, so met the secondary endpoint of improving path CR. We have not seen progression, event-free survival or overall survival data yet, so that is eagerly awaited. And it kind of hinges on the question of how good of a surrogate is path CR for outcomes, and probably how many PD-L1 positive patients are in here. In a little bit of a negative piece of news, Keynote 585, which the schema is shown over here on the left, it's another large perioperative trial asking a similar question about adding pembro in the perioperative space. Primary endpoint here is path CR, co-primary event-free survival and overall. And like Merck likes to do, they had a hierarchical statistical plan. So if they hit path CR, then they had the power to formally test event-free survival. And then only if they hit EFS would they hit OS, would they test OS. And unfortunately, we saw that, yes, they hit path-CR rates, so they tested EFS, but that was negative. So no improvement in event-free survival, and therefore overall survival was not tested. And so here, this is a little bit of a cautionary note about just throwing PD-1 inhibitors at everybody, and certainly we'll wait to see this data in terms of some of the subgroup breakdowns, and that's expected at an upcoming meeting. This is a really interesting piece that I thought I'd just point out as we get to the very end of the talk, but this is a very small trial from Dr. Yoon at Mayo Clinic. They were asking a kind of a question about front-loading chemotherapy with more systemic therapy. So they took patients with locally advanced gastroesophageal adenocarcinomas, randomized them to essentially cross 5-FU oxalic radiation versus, think of it like FLOT. This is DOX for 2 cycles followed by the same chemoradiation. And there was no statistical improvement in path-CR, which was the primary endpoint. But as they had long-term follow-up of these patients, what you saw was a pretty clear divergence of the survival curves. So disease-free survival and overall survival. Here we see that in the people that got more systemic therapy, the DOX-containing arm A, you see the median survival was 5 years versus about 1.5 years. And in the disease-free survival in patients who had complete resection, you see the group that had substantially greater systemic exposure, the DOX-containing group, they had a hazard ratio of 0.4 and over a doubling of disease-free survival. So I just show this to throw a little bit of caution to the idea of path-CR as a perfect surrogate for OS. But not to forget of the idea that better systemic therapy may still translate to better micromet eradication and better outcomes. So what's going on? 585 and Matterhorn are still waiting the primary endpoint readouts. Top Gear and ESOPEC are other very important studies. Perhaps they get a little bit less attention because they're not immunotherapy containing, but still very important question. And then the big hole that I'll leave you with is we're really missing biomarker-enriched trials for localized cancers. We have validated targets in the metastatic setting, HER2, MSI, FGFR2, Claudin 18.2. If the biology is real, then this should be able to be translated into the non-metastatic setting in well-designed trials. And so certainly all of us are working around the world together to design and try to conduct some of these trials, and look forward to working with all of you to try to think through this. And then, of course, refining our outcomes with some of our newer tools like ctDNA may allow us to better select patients for a given strategies, whether it's escalation or de-escalation, etc. So I'll leave you with these final take-home points that I won't go through. I think the immediate thing on practice for everyone starting tomorrow is that, we really need to drive down the importance of testing the localized patients for MSI high and microsatellite mismatch repair deficiency, because this is really a different disease group and they need to be managed differently. We don't know the best immunotherapy containing strategies, particularly in non-metastatic setting, but these are ultimately very important questions. This is me, and I will stop there.
Was just interesting and amazing. Actually, I had a few questions, but you just rose it in the end. So regarding this gap in the biological therapy, actually, I wanted to ask you, because it's really weird that we do have approved regimens for HER2-positive breast cancer, and we don't have nothing for gastric cancer. And I think it's really should be studied. Do you have any, phase 2 trials in MGH about it?
Yeah, we thankfully have one, which is definitely not enough, but we have a study which is in conjunction with Sloan Kettering, which is essentially taking Keynote 811, FOLFOX, Pembro, and trastuzumab, and doing it in the non-metastatic HER2 population. So patients it's asking kind of 2 questions at once. One is bringing HER2 into the neoadjuvant in this structure, because we've seen some negative data with like Petrarca and RTOG 1010. But it also moves all of the therapy into the neoadjuvant setting. So patients get 8 cycles of FOLFOX, Pembro, and trastuzumab with a PET scan and endoscopy after the 4th cycle. and then they get surgery, and then they get an adjuvant year of pembro and trastuzumab for a year. And we don't know if this is going to be the best strategy. And certainly when I saw Dr. Smith's Vestige data, it did make me wonder if among patients who still have residual disease, whether biologic only in the adjuvant is something we might want to rethink. But that's the trial that we have. And certainly there's opportunity to move a lot of other trials. I know that there is some designs for Claudin, perioperative Claudin containing therapies. And I think that is definitely worth exploring for sure.
So big, so who has this high expression of Claudin receptors? If I'm not mistaken, they're not so often as HER2 mutant.
Good question. So you're getting at a very important question for the field, which is biomarker overlap. How common is someone going to be Claudin positive and HER2 positive, et cetera? And at least from the data that the retrospective data that I've seen, it seems like Claudin 18.2 is more a gastric lineage marker, and it kind of runs through all of the biomarker subgroups. So there's probably going to be equal portions of Claudin 18.2 positive, HER2 positive, and HER2 negative patients. And then it will be about prioritization. If someone's double positive, how do we know what to do? Well, right now we don't. I think we're all going to look at the data and say the data is better numerically for HER2 positive. So if someone's dual positive, we'll go with HER2 for now and then come back to the Claudin. But in fairness, we don't really have the data, and certainly open to others' opinions on that one too.
Let's combine.
Yeah, exactly.
Other thing, yesterday we had colorectal section, and there were a lot of talks that in colorectal we are moving to neoadjuvant, so adjuvant is go into the past. So what do you think about these strategies for upper GI tumors?
Yeah, I think worth exploring. We certainly know that after surgery, and as good as your surgeons are, as good as our surgeons are, like giving someone chemotherapy after a gastrectomy is hard. It just is. And we know that from data over and over again. A large portion of patients don't even start it, and a smaller portion finish. So it does make you feel like, well, let's front load it and see if that's a better way. It certainly will probably be more tolerable and may improve the R0 resection rates, and it will probably filter out those people who had bad biology and were going to metastasize out early on and never would have benefited from surgery. So there may be some good things to total neoadjuvant therapy in upper GI cancers. But as I saw the Vestige trial, I've been trying to be thoughtful about this as we go forward, because that was a very high-risk population, and maybe they were just going to do bad, but at least it does suggest that there may be chemotherapy is better than immunotherapy in that setting, at least we can say from the trial. But I still think that total neoadjuvant is worth exploring. It will probably allow us to select patients a little bit better with longer preoperative exposures. But there's still going to be a portion of patients who have a high residual disease at the time of surgery, and we need to know what to do with them. They're probably going to need something adjuvant.
And really quick provocative question, I guess, so you think that not only you, we heard a lot in ASCO about it, that MSI high population is just other type of population. Should we test ctDNA for MSI high early stages for selecting whether they need some further treatment or not?
Yeah, so I think in the localized patients, tissue is still the gold standard for MSI testing. I believe that the rates of ctDNA shed are certainly lower in the localized cancers, and so ctDNA alone is probably not quite ready for prime time for selecting. I would say in combination with tissue, that's definitely a viable approach. I would say that if I had a stage 2 patient who we did ctDNA and they picked up MSI high, I would believe it, but I would want to confirm it on tissue. And if it wasn't picked up, I would wonder if that was an issue around the quantity of ctDNA and the ability to actually conduct the analysis more so than the biology. So that's a situation where we really still need tissue for testing. So I think incorporating it in, and maybe the application will be people who are ctDNA positive pre-baseline and then preoperatively have cleared along with a great response clinically and endoscopically. Maybe those are the people who don't need surgery in the MSI-high group.
Good perspective, I guess. Sam, thank you very much for your presence in our conference. It's really great to see you, and it's really was interesting and fresh information having like June's information in here. And I would like to present our next speaker is Dr. Lizzy Smyth, who is working in Oxford Hospital, and she will present us a presentation named Checkpoint Inhibitors and Beyond for Advanced Gastroesophageal Cancer. Lizzy, hello. You're muted.
Hi, Veronica. Thank you so much for inviting me to talk at the meeting. And hello to everyone in Ukraine. I hope you're all keeping well and safe. It's great to talk to you, and hope I'll be able to come to see you in person someday. So thanks for the invitation. I'm in a rainy Oxford today, and I was asked, unlike Sam, to come and talk about checkpoint inhibitors in advanced disease. And how well we've been doing in gastroesophageal adenocarcinoma. So I understand, Veronica, this is a kind of mixed audience, isn't it? So I'm going to, is it oncologists and surgeons, isn't it?
It's mostly surgeons, to be honest, but there is partially, they're clinical oncologists as well.
And I know some surgeons are really up on immunotherapy, but I'm gonna aim for a surgical audience so that they don't all fall asleep with the oncology detail, because this is treatment of advanced disease. Okay, so let me share my slides. Where do I go? Do I have the opportunity to share here actually on my login, or does somebody else? Do you need to give me the ability to share?
Actually, you can. Everyone could.
Can I? I can't see the. Oh, I see it now. My apologies. Okay, so here we are. Okay, I got it. So today I'm going to talk about advanced disease, and I know Sam has talked to you about perioperative setting and how we cure about half of patients, which is good, but we hope to do better. And in advanced disease, we sadly don't cure many patients. The median survival has been less than a year thus far, and until the advent rate of immune checkpoint inhibitors, with the exception of HER2 cancers. Although we're starting to see long-term survivors, and I'll talk about how immune checkpoint inhibitors have changed the landscape for us over the past couple of years. So you don't need to know all these if you're a surgeon, but what this shows us, these are all the trials that we've done in gastroesophageal adenocarcinoma. So that's including esophageal adenocarcinoma and gastric adenocarcinoma. And I speak of them as a single entity because in the UK, what I mostly see are junctional cancers. So we see about 70% junctional cancers and about 30% gastric cancers. It might be different in Ukraine because usually as we move east through Europe, we see more gastric cancers. So I bet you could tell me that you see more gastric cancers. Biologically, they're very similar though. In the beginning, we started developing these drugs in chemorefractory cancers, so patients who'd had lots of chemotherapy before. And we showed that immune checkpoint inhibitors were better than no treatment. So that was easy. But we know that they're on their own, PD-1 inhibitors, which are the most basic form, one of the first generation of immune checkpoint inhibitors, aren't that effective when we give them to every patient. So if we give them to unselected patients, and Sam has been talking about biomarkers, we see response rates of about 10%, and they improve survival by a fraction. So it's really about finding the patients who benefit most. And when we compared those immune checkpoint inhibitors to chemotherapy, in fact, chemotherapy won. So chemotherapy was better than immune checkpoint inhibitors, and that's because they aren't so effective on their own. And what we found was most effective was when we put immune checkpoint inhibitors with chemotherapy. And that's what we've done laterally over the past 2 to 3 years, combining them with platinum and 5-FU chemotherapy, which is what we used as a standard of care. And I'm going to show you how effective that's been and what that means for patients in a minute. So these are the licenses that we have all over the world. And what the message that I want you to take from that slide is that the same drugs are used, mostly anti-PD-1 inhibitors, so nivolumab, pembrolizumab, And to be honest, you can't draw, the different trials have been done, but you can't really draw a line through the efficacy of these drugs. It is a class effect for the most part. So one is the same as the other. In Europe, we tend to use them for the patients who are most sensitive. So those are the patients that have PD-L1 on their tumor, and PD-L1 is a protein that shows that the tumor has already evoked a response in the immune system. And the T cells, which are the parts of the immune system that get rid of the tumor, have been there and they're tired. And that's what PD-L1 is telling us. So in Europe, we tend to focus on the patients who benefit most. All over the rest of the world, the license is for all patients. However, the guidelines, which is, I suppose, to a degree more academic than the license, are all recommending that we use them only in the patients who express PD-L1 at pretty high levels. And that's about between a third and half of patients, depending on the data set that you look at and the test that you use. So there's about a third of patients that are sensitive. And this is what makes patients sensitive to immune checkpoint inhibitors. So, you know, we talk about in oncology that there's a spectrum of sensitivity to immune checkpoint inhibitors. And that's driven by things that are happening in the tumor. So tumors that have a lot of mutations, like the mismatch repair deficient tumors that Sam's just talked about, they've got proteins on the outside of the cells that are seen by the immune system, and those T cells come and attack the tumor. So those are the ones that are most likely to benefit, and we call those kind of T cell inflamed. And then we've got immune excluded, which means that they might have those proteins present on the tumor that the immune system sees, but the T cells, the immune system, have difficulty getting to the tumor. And that can be for a variety of reasons, because the tumor is very dense or it doesn't have good blood vessels. And we need to understand how to overcome that to get the immune cells there. And then you've got this problematic bunch of tumors that don't have any proteins that the immune system sees, and no T cells nearby. And we're also trying to figure out how to deal with those. And the treatment will probably be additional therapies, so combination treatments. And if you look at, so this is all the tumors that we have broken down into which have the kind of inflamed tumors and the excluded tumors and the immune dead desert tumors. And you can see that gastric cancer has about 1/3 of patients who have these inflamed tumors. And that makes sense when we see that's the proportion who have PD-L1 protein on their tumor. And those are the ones who benefit from immune checkpoint inhibitors, really. These are the results of all the clinical trials that have been done, not every clinical trial. These are the international clinical trials that have showed a benefit for immune checkpoint inhibitors in advanced disease. And I'm not, thankfully, going to go into all of these in detail today. But what we saw is that when we add a checkpoint, a PD-1 inhibitor, to chemotherapy, that you improve survival by about 25 or 30%. If you give it to patients who have high levels of PD-L1 in their tumor. The higher the level of PD-L1, the better. So if you go from a level of 5, you've probably got a 30% improvement in survival, to a PD-L1 level of 10, you might improve survival to 40%. So it's about finding out. So there is an improvement in survival, and that pans out. How that pans out for patients is, now is about a 3-month difference in the average survival, which we call the median in oncology, I suppose. Well, I know median and mean are different, but median. And so, but what that means really is, so median is the wrong way to look at long benefits from immune checkpoint inhibitors. It's the way we've traditionally looked at benefits from chemotherapy, but really where we see the benefit from immune checkpoint inhibitors is in response, but also in the long-term survivors. Because, you know, with chemotherapy, you get a response and then it goes away. But with the immunotherapy, you get a response, and for some patients, it lasts. And so what we see, this is Checkmate 649, it's one of the biggest studies, and we've got mature follow-up on that, is that you improve the number of patients alive at 2 years from 20% to 30%-ish. So you've got a 10% benefit. So that's good. I can tell my patients now that they have a 30% chance of being alive in 2 years, which is better than an average survival of 1 year when you think about it. And then we've got the 3-year follow-up, and it's showing that 20% are alive at 3 years. So you still do see a fall off. in the long term. But 20% at 3 years is certainly better. It's double what we saw before with chemotherapy. So those benefits are relatively modest. We need to keep working on that. But the fact that we're seeing 1 in 5 patients alive at 3 years that we treat with immune checkpoint inhibitors is encouraging. And this should lead us, I think, in future to think about how we think about patients with limited metastases. So I'm talking to a bunch of surgeons now, and I think we need to, I don't know if Sam has touched on it, but to think about moving on to patients with limited metastases, oligomets, and whether, if they've had a benefit from immune checkpoint inhibitors, whether, you know, doing an operation on their primary or doing an operation on their primary and metastases might make a difference. So I think that does open up that question for us, like kind of like we did in colon cancer. And this slide is just demonstrating that it's not just nivolumab that has these benefits, that all the PD-1 inhibitors have the same benefit. So I don't know what is available to you locally, but access to any PD-1 inhibitor plus chemotherapy will help the patients who express PD-L1 on their tumor. So whether it is tislelizumab or pembrolizumab or nivolumab, the effects are all the same. And the question is, how do we identify the patients who are likely to have a long-term benefit? And this could perhaps influence how we think about patients we might want to operate on, perhaps, although I don't think it should be exclusively these patients. But for example, if you have an 80% reduction in your tumor measurements when you're treated with chemo plus nivolumab, you have a 60% chance of being alive, kind of at a 54% chance of being alive at 2 years. So your chances of survival are much better than if you have the same reduction of chemotherapy. So the depth of response and how much the tumor shrinks is very predictive of the long-term benefit. I think more work needs to be done on that. We've shown that before in colorectal cancer with chemotherapy and cetuximab, actually. So I think this is something that we might want to think about in prognosticating for our patients. So I realize that that I'm talking to a very mixed audience, but we have challenges with the biomarker that we use. So I've suggested that we need to test for PD-L1, and this is how we should select patients for treatment. But PD-L1 is not perfect. So anyone who works in the lab knows that how we stain slides matters, and PD-L1, we're using a lot of different antibodies, and we don't know what the right cutoff is. We need to use cutoffs, unfortunately. We know that PD-L1 exists on a continuum, but unfortunately we need to select groups of patients, for example, for funding decisions. Certainly in the UK, we wouldn't be able to afford to treat every patient with a PD-1 inhibitor. So we do need to use those cutoffs, so we need to work to establish the biomarker accurately so that we select the right patients. If you're taking a biopsy for PD-1, you should take it deep, because PD-L1 is expressed at the edge of the tumor where it's invading. And I think that we're working on a couple of projects where we're going through PD-L1 staining with many pathologists so that we can develop a consensus statement on how best this can be done. So that's something that's in the works. Now, I know that Sam has touched on this, and it's very important. So this is the group of gastric cancers and junctional cancers that you don't want to miss. And you don't want to miss them if they're operable, and you don't want to miss them if they've got advanced disease. So these are the MSI tumors or the MMRD tumors. So it's about 3 to 5% of patients with advanced cancer. It's more common in stomach cancers, but does occur in junctional adenocarcinoma. PD-L1 staining doesn't pick up all of these tumors, so you need to do mismatch recruit efficient testing, which is an IHC test, as well as PD-L1. And you've got these extraordinary, so in contrast to the standard gastric cancers, you've got these extraordinarily high response rates to PD-1 inhibitors on their own. So you don't need the chemo for these patients. So when you treat an MSI gastric cancer with PD-1 on its own, you get a response in about 50% of patients. If you add ipilimumab, or an anti-CTLA-4 drug, which is a very powerful immune checkpoint inhibitor, you can increase the response rate to about 70%. And there's a couple of studies there showing that, you know, adding chemotherapy to the immune checkpoint inhibitors in MSI cancer doesn't really improve the overall survival. And in fact, it might decrease the hazard ratio a little bit compared to chemotherapy. So for me, I'm quite happy for most of these patients not to recommend chemotherapy. There is a little bit of debate about that. So, which I think is fair, because if we look at these are accumulated data from a number of different trials that looked at PD-1 inhibitors and chemotherapy for MSI patients, and you improve progression-free survival, but not overall survival if you add chemotherapy to PD-1 inhibitors. But it may be that some patients are going to progress anyway. There is a nice data set that I think Sam was involved in, looking at these patients in the real world. Patients who have bad cancers, so patients who have feeling poorly, so we use performance data, so who don't have a good energy and strength, patients who have ascites, patients who have bone mets, they don't tend to do very well with PD-1 inhibitors on their own and experience early progression. They'll often experience early progression on chemotherapy too, but maybe to give them the benefit of the doubt or a chance to let immune checkpoint inhibitors work, these would be the patients who you might want to give chemotherapy with as well. So I think that's nice research that's come out recently. And so, just in the interest of time, I might skip on a few slides to ask, some of the questions that we've been asking are, can we stop chemo for patients if these immune checkpoint inhibitors are so good? And the answer for MSI patients, in my opinion, is yes. But for all other patients, the answer is no at this time. So even in the patients who have the highest level of PD-1 protein, PD-L1 protein, which I mentioned, so we did some trials using checkpoint inhibitors on their own instead of chemotherapy, and the response rates are not good. So the response rates are about 25-30%, which is a good bit less than chemo. So chemo would be 40-50%. And the patients who treated with checkpoint inhibitors alone progress early, so their cancers grow quickly. And as a result of that, some patients will die sooner than they would have had they received chemotherapy first. And that's because we know that gastric cancer is a bad cancer. So we need to shrink the tumor and really reduce the bulk of the tumor to allow immune checkpoint inhibitors to work. And we know also that certainly in the UK, I don't know about Ukraine, but we see a lot of patients with pretty advanced cancers. And so we know that the balance of how immune checkpoint inhibitors work is the ratio of those T cells in the body to the tumor, and so if you've got a lot of tumor, you need a lot of T cells. So if you reduce the amount of tumor, then you can reduce the amount of T cells. So it works better. So reducing the tumor it makes sense. Don't use it on their own. And some of the questions are, another question that we ask is, can we stop chemotherapy early if we give immune checkpoint inhibitors? And the answer for that is no too. So this is very like the adjuvant trial, I think, that Sam just showed you. Germans took some patients and gave them chemotherapy and then 6 weeks and then stopped it and gave them an immune checkpoint combination of immune checkpoint inhibitors instead, stopped the chemo. And unfortunately for the patients who stopped the chemo, they progressed early. So their cancer started to grow really quickly. So the message that's coming out here for most patients, I think, with gastroesophageal cancer is that we need chemo. So chemo, there are cancers like kidney cancer, sometimes lung cancer, melanoma, for example, where chemotherapy is gone almost for groups of patients. It's not going to go away in the short term for patients with gastroesophageal cancer until we do a little bit more work figuring out how to make these immune checkpoint inhibitors work better. So Sam talked about, I think well, I know Veronica asked a question about HER2 in the perioperative setting, and HER2 has been our most important biomarker in gastroesophageal cancer for a number of years. We target it with trastuzumab. It was our only effective targeted therapy. And what we found out recently is that patients with HER2 positive gastric cancer, most of them, also have really immunogenic tumors. So if you remember those proteins that I told you that are on the outside of the cell that attract the immune system to the cancer, well, they're also present a lot in HER2 positive gastric cancer. And you can see when you look at these looking at RNA expression of immune markers that HER2 positive tumors are really hot. And they express high levels of PD-L1 protein, most of them. So about more than 80% have high levels of PD-L1. So it would seem very attractive then to combine chemo and trastuzumab, which is our standard of care, with an immune checkpoint inhibitor. And so that was done in the Keynote 811 study, and Keynote 811 is going to report some survival results at ESMO this year. And what they showed in that study, these are the response data, is that when you give chemotherapy, trastuzumab, plus an immune checkpoint inhibitor, that you improve the response rate from 50%, which is good, to 70%, which is great. And so this was led to a license in the States and US. It's not enough for a license in Europe. And, you know, I think that what we need to see now is the survival data. What's been interesting is that we've seen a press release saying that the survival data is coming, progression-free survival was positive, but it was only positive for patients who also expressed PD-L1 as well as HER2. And that's a lesson to us, because I think that when we think about, and I think I heard Sam say this, you can't just throw one antibody after another. I mean, that's not always going to work. You need to understand whether that specific tumor, or maybe that group of tumors, is also sensitive to immune checkpoint inhibitors. So this is all about the context of the biomarker in patients as well as groups. I hope what we'll see when we're looking at HER2 plus immune checkpoint inhibitors is a survival of about 2 years. So this is maybe more. So this is a German study. It was a small study that looked at that type of combination, and they saw survival of 2 years. And that would be good. So that would be extraordinary for gastroesophageal adenocarcinoma. So you touched on, I think, Claudin, which is really important. And I'm not going to talk about it at length today because it's an immunotherapy talk rather than a targeted therapy talk. But Claudin is really important biomarker that's coming your way, even in the surgical setting. Sam touched on whether there will be perioperative studies with Claudin, and there are. So we're trying to develop those. So Claudin's present in about 40% of gastric cancers. It's really interesting biomarker because unlike the other biomarkers, it's not driving the cancer to do anything. Claudin is something that is on the tight junction, so it's on the stomach lining, and then it just ends up on the cancer cell. But that makes it a good target because it's not anywhere else in the body, and so we see less toxicity when we target it. And we have 2 positive phase 3 trials in advanced disease with an antibody called zolbetuximab, and that has improved survival. And there are studies ongoing looking at the combination of zolbetuximab plus chemo plus immunotherapy. And there are also lots of other drugs in development, including Claudin ADCs and bispecifics, which I'll talk to in a minute. There's also bemarituzumab. This is something that Sam has also been involved in. So that's a FGFR2b inhibitor, again targeting a biomarker that's present in about 1 in 6 gastric cancer patients. And so these are all being evaluated with and without immune checkpoint inhibitors. And I think what's critical for us is to understand the interaction of those biomarkers with PD-L1. And that's for 2 reasons. So the first is we don't want to give our patients the toxicity of a PD-1 inhibitor on top of an antibody if it's not going to benefit them. And the second is when we're getting into costing 2 sets of antibodies as well as chemotherapy, this is going to be extraordinarily expensive for healthcare systems. So I think we need to get the best value for our patients. And as oncologists and people who work in drug development, we need to explore the biomarkers to find the patients who benefit the most. So there are, I think I'm kind of running out of time a little bit. So there's some other pathways that are in development that are certainly of interest, and they're biomarkers called TIGIT. So TIGIT is another biomarker that's present on T cells, on tumor. It has been somewhat successful in other cancers like lung cancer, although that is still in development. We've seen responses to anti-TIGIT antibodies with immunotherapy without chemotherapy. And the results from early trials look pretty promising, but it's very early in development. And then there are targets that don't look terribly successful, unfortunately. So LAG-3 has been successful in melanoma with relatlimab, but we have 2 trials now in gastroesophageal adenocarcinoma that have shown negative results for LAG-3. So the first of those was in a trial in advanced disease, and the second of those was with chemoradiotherapy, and patients treated with immunotherapy plus LAG-3 plus chemoradiotherapy had quite bad toxicity. compared to patients treated with PD-1 alone. So it doesn't, although it may be, we need to see the long-term survival from that. So maybe, and I think that's important, because just because that's a lesson, just because it was successful in melanoma doesn't mean that it's going to be successful in gastric cancer. And so we really need to understand, again, what LAG-3 does in gastric cancer compared to melanoma. So very briefly, I would touch on some other approaches that we are taking. So the first is combining. So if we talk about, I've really talked about the patients who are sensitive to immunotherapy so far. And I think that there are other approaches in the patients who are less sensitive. If you remember, I said one of the challenges is getting those immune cells into the tumor. And they're often blocked because of poor, faulty blood vessels and angiogenesis. And so combining drugs that target angiogenesis, we have tablets called tyrosine kinase inhibitors, which do that in many diseases, looked very promising when it was examined in some studies in Asia with really high response rates of about 60%. But we've learned time and again that studies in Asia don't always show the same results when we test them outside of Asia. And certainly results in an American study recently looking at that approach show lower response rates and maybe not so encouraging survival. However, that's been now combined with, so you're using the anti-angiogenic drug plus immune checkpoint inhibitor plus chemotherapy in a very large randomized trial called LEAP-15. And this waterfall plot here, looking at the response rates of, I don't know, looks probably like 100% response rate there, but in a small cohort, we're waiting on the results of those. So it could be something that we use in future, but for me, combining all those drugs together and also the early stopping of chemotherapy in this trial to allow a maintenance of the two drugs, of the anti-angiogenic and immunotherapy, might be problematic based on what we've seen in other studies. I get to something that probably I could let Sam chip in on, because this is his trial. So for those tumors that have no T cells, no immune response at all, one of the pathways that's been identified as being responsible for that is the Wnt pathway. And that's a pan-tumor marker for a lack of T cells in the tumor. And one of the proteins that's involved in that pathway is called DKK1. And the presence of that means that the area around the tumor, what we call the microenvironment, is quite negative towards T cells. But there is a drug called DKN-01, which targets that protein called DKK1. And it's shown very encouraging results in early trials, even in patients who've become resistant to immune checkpoint inhibitors, so good response rates. And it's being trialed now in combination with chemotherapy and a PD-1 inhibitor. And Sam showed the results at ASCO, and you can see them there on the right. The responses were good, so more than 70%. And the survival was actually way more than we see, much more than we see even in our immune checkpoint inhibitor trials, although this was a small trial, so you can't overinterpret it. But that's being looked at now in larger trials, and the results seem quite encouraging. On the home stretch now, I think I have 2 more slides to go, but this is one of the two later slides, the last slides that I'm going to present, are really looking to the future. So one of the two of the treatments that we're most excited about, because they haven't worked in any solid tumor before, is CAR T. So CAR T are taking the patient's T cells and putting a specific target on them and giving them back to the patient where they attack the tumor. So it's modifying the patient's T cells. And this has been very successful in lymphoma and leukemia, and is curative in those diseases. But there was always a problem finding the target in solid tumors, because in hematology, there's a lot of redundant targets that you can use. So you can target CD19 on cells and it doesn't really affect the patient. But in cancers, most of the targets on the cancer are also on other parts of the body. So it's been very difficult to do that safely because of side effects. And as I mentioned to you, Claudin 18.2 is a really interesting target because it's only present on the stomach lining and the tumor. And so using CAR T as a target, using Claudin 18.2 as a target for CAR T is smart. And so this was the first trial in solid tumors that really showed a significant benefit for CAR T. So this was patients mostly with gastric cancers that expressed Claudin 18.2 on their tumor. And about 50 patients had the CAR T therapy. Of those, about 30 were gastroesophageal. And they had responses in almost 60% of patients. And really importantly, there was very little toxicity observed, so which was fantastic for a solid organ CAR T. So this is very, very exciting. Now, CAR T are challenging. The reason why CAR T are challenging right now is because to give CAR T, it's like giving a bone marrow transplant. You need to bring the patient into hospital. You need to give them lots of chemotherapy to knock out their immune system so that the CAR T can begin to work. And you need to, this is a risky period for the patient because they've got no immune system. You give them the CAR T, the CAR T have got to work against the tumor. So they need a lot of monitoring and a lot of care. And not every center will be able to deliver this. So in the UK, we have only got 8 centers for CAR T. And so the question is, will this be something that we deliver at specialized centers, or will we be able to develop it as a treatment choice realistically? Because it's also very expensive. So we need to see, especially the longevity of response to this. I think it's going to be a key question in future. The last type of drug that in immunotherapy that I am particularly excited about is bispecific T-cell engagers, so BiTEs. So we call them BiTEs. And what's exciting about these is that they take a protein which is present on the tumor. So they're like a dual antibody. You've got 2 bits to it. And one part links to something that it can see on the tumor. And the other part links to CD3, which is a powerful signal on immune cells. And so it links to the tumor and it brings the immune cells to the tumor where it sets up a reaction allowing the immune system to see the tumor. And, it's causing a synthetic immunity. And so these have the potential to be very powerful. And what's nice is that they are off the shelf. So you don't need to design them using your own T cells. You don't need to give bone marrow transplant type medication beforehand. They're very powerful and they can have side effects that cause cytokines to be released in the system, so inflammatory markers in the system when you receive them or in the couple of days afterwards. So they're powerful, and so these are being developed in gastric cancer, also targeting Claudin 18.2 amongst other markers. And I think these are going to be very successful and very accessible for patients in future. So that's the end of mine. Hopefully I haven't gone over too much. In summary, immune checkpoint inhibitors are now part of our standard treatment for patients with advanced gastric cancer. We're seeing long-term benefits for selected patients, mostly those who express PD-L1. In future, we're going to be combining this with targeted therapy, but it's all about understanding whether in individual patients as well as groups of patients, whether that target sensitizes them to immune checkpoint inhibitors. There are some ways that we can evade the immune system, like blood vessel formation and Wnt that we might be targeting. And I think most excitingly, we're seeing treatments beyond our standard treatments, so beyond PD-1, like the CAR T and the BiTE, which I think are going to give us even better results in future. So hopefully that was not too technical, and I really enjoyed it. So hope there's some questions for me.
Lizzy, thank you very much. As always, I mean, as Sam as you are just great in your talks. I have actually a few questions. One was answered in one of last slides. I wondered how could we hit this cold tumors for immune treatment to work, but you answered it. So yeah, we should try to target like vessels, and so you showed this 2 slides, but maybe some other ideas.
That's one of the questions. So I think that those type of approaches like Wnt or angiogenesis are kind of really from first principles and biology. But there's a lot we don't know. So because you know, an immunologically cold tumor, if that responds to chemo, can actually become an immunologically hot tumor. And so sometimes you might see a PD-L1 negative tumor and treat it with chemo, and all of a sudden it's upregulated PD-L1 and you see an influx of T cells. So I think that there's still a lot to learn. So that there's a lot of, and also, you know, maybe taking antibodies that treat, so maybe, that we don't know this, I'm just hypothesizing, you could take a Claudin 18.2 antibody on a cold tumor and it sets up the antibody sticks to the tumor and then the T cells are attracted to the antibody, so it's ADCC. So I think and radiotherapy is another option. So I think that there's a lot to learn. I think baby steps pick up those hot tumors or those cold tumors, but there's a lot to learn. What's interesting is, so you know, the bites, what's nice about the bite is that you are inducing synthetic immunity. So you can have a cold tumor with Claudin 18.2 and you bring in the CD and then you set up kind of setting up those signaling pathways like interferon gamma, and you make memory T cells. So that's the other way. So you bring the T cells to the tumor. So there's many options to kind of intervene in that cycle of immunity.
Do in our science. Other question, I heard clearly your message that, well, patients should receive chemo, but what do you think about, I mean, it should be like double chemo, like let's say 5FU or capecitabine plus oxali. Can we reduce this doublet to just one, like to leave for 5FU and capecitabine only plus immuno, or what do you think about like using oxali?
That's a really interesting question. So I think that, you know, certainly we want to get tumor shrinkage as much as we can in the beginning, and using oxali for prolonged periods of time is kind of hard on the patient anyway, because they get neuropathy, and I'm always telling my patients they won't get more than 4 months of oxali. But these are questions that haven't been asked yet. So when can we de-escalate? You know, can we just do 5FU alone? I think there are also really pertinent questions that have broader issues. So, for example, with immune checkpoint inhibitors, we know that the doses that we're using are too high. So they were developed they are marketed at a certain dose, and they're probably effective at much lower doses. And we should probably be looking at, especially in low middle income countries, at doing trials of de-escalating checkpoint inhibitors, because it's quite likely that in patients who are sensitive, that they'd be sensitive regardless of the dose that we use now. And I'm not advocating that everyone gives it. We start giving half doses of nivolumab because it needs to be approached systematically. But I think that in terms of payers, which could be patients or it could be governments, and also kind of having the most number of patients benefit from these, this is something that we could do.
Actually, that was my next question. So whether should we de-escalate immuno, so where to stop? Because it's the most often question that asked by patients after lifestyle things. So they usually ask for how long? And we say, well, lifelong, but it's not really easy to say. And it also, you know, I mean, when immuno works, it works whether you give it or not, because I can see with patients who had toxicity and we had to stop due to toxicity, they still have a response for a long period of time. So can we de-escalate the quantity of immune checkpoint inhibitors not to give them lifelong? How do you think? I mean, or have you
is based on personal experience rather than any level of data, but certainly if a patient has toxicity from immune checkpoint inhibitors, they are having such an excellent response to the drug that they probably don't need any. I would be reluctant to re-challenge for grade 3 toxicity, for example, for patients. So most of the trials these days, and we do though see some patients recur or their disease progresses when it stops. So I think that happens in about 1 in 3 lung cancer patients, maybe 40%, and it happens in about 1 in 6 colorectal MSI patients. So for some patients, they need maybe continuous stimulation, and other patients they don't, and we genuinely don't know. So I think you need to have a and if they have access to a re-challenge progresses, then that's fine. But this, I think, at the moment is a case by case basis. Certainly, if we use ipilimumab, or the benefits are more long term, and I think in future the next generation of CTLA4 inhibitors being made now, that we will, if they get integrated into first-line therapy, that the responses will be more long-lived. I certainly don't think you need to give anti-CTLA4 continuously. It's usually has quite a lot of side effects.
Thank you very much. I guess that's all for questions. So I really appreciate your time and thank you for joining us. It was really, really, really appreciate. So hope to see you soon on ESMO, I guess.
Thank you. Yeah.
Yeah.
So nice of you to invite me.
Thank you very much. І я хочу подякувати нашим слухачам за увагу. На цьому ми завершуємо наш другий день конференції і чекаємо вас на подальших заходах. На все добре.